Patrick, আমরা চাপ हाँ
आणि सरस आवाज बघतो ठीक आहे nothing yes 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 no problem अभी तो ठीक है
माइक ऑन है माइक ऑन माइक ऑन बोला
hello hello that's it
एक मिनट
આને છે ને સેજ નીચું કરી લો એટલે આ નીચું જતું રહેશે કર્ટેન છે ને થોડો નીચો કરી દો એક મિનિટ હો બસ થોડો નીચે લગાડી દેજો આગળ લઈ લો સ્ટેન્ડ
જીતુ
બસ અને આ તારું આ નાનું કર
જીતુ જીતુ જીતુ
યસ ડન ડન કરો યસ ધેટ્સ ઇટ
माइक चेक
માઇક ઇઝ ચેક ઓલરેડી
क्या गया આપણે હેલો આ વચ્ચે લાઈટ ને સેટ કરો ને બીજી માસ્ક
is this is just like a hammock. This femur is like a hammock. And this is the one soft tissue sling here, another soft tissue sling at the back of the femur. Abductors are, you need to bring it forward. Gluteus, you need to bring it backwards. So that's just to retract the soft tissue and create a window where you can work upon it, depending on your acetabulum component and the femoral component. So this is superior anterior pin. This is posterior inferior pin, you can say. This is an anterior spike. This is, I think, very important not to push. Initially, you can fracture the acetabulum or you can injure the important structures at the front. So this is one very gradual with this retractor. I think this is very important. This retractor is very important to us. The second retractor we are just to demonstrate here may not be needed when we do reaming is the inferior and posterior retractor. This is a bi-pronged retractor at the inferior surface.
Yeah, Dr. Shukla.
Yes.
Yeah, there is a repetition.
Pardon? Hello, can you hear me? Hello. Hello.
Yeah, hello. Can you hear me?
Yes.
Yeah. Please go on with the acetabulum. We have a good exposure. Can you rotate your camera so that to show the acetabulum cup actually?
You can rotate.
Yeah.
From which angle you will show?
Yeah, all the 360 degrees of exposure of the cup.
Retractor.
Yeah, from the surgeon's view.
Yes.
Little bit zoom now. Now we can see the acetabulum nicely. Can you zoom? Yes. Yeah. Can you see TA?
Yes, sir. Fortunately, we are able to see TA very well inferiorly. I will try to highlight this. Nibbler, please. So it is, I think, entrapped a bit in the osteophytes, inferior osteophytes. Water, please. So I think here it is somewhere here. I need to remove the osteophytes. I think then we will be able to appreciate better. But this is a cotyloid fossa, the medial wall. I think you can see medial wall, the deepest portion of acetabulum. And these are the inferior osteophytes, anterior osteophytes, and posterior big osteophytes as well. So can we start further?
Can you hear us?
Hello, can you start further?
Yeah, can you hear us now?
Yes, yes, we can.
Because there is a lot of disturbance in between.
Yes.
Did you remove the inferior osteophyte? Because we missed that step actually.
We have not yet removed the osteophytes.
Okay.
This is seen now. This is the inferior osteophyte. You can see where the suction is there.
Yeah, very good.
So all the osteophytes are kept as it is right now.
Okay.
So now just we are going to start with the, I think the exposure is, we are okay. We are going to fine tune with little bit of soft tissues anteriorly and little bit posterior inferiorly. And then we can just start with the preparation of acetabulum.
Yes, yes.
Sometime if you are having more idea about the medial thickness or the medial osteophytes, you can use a drill bit. You can just drill it and try to reach to the basic understanding of the thickness of the central osteophytes.
In this complex cases, do you use any CM or you directly start reaming?
No, we don't use CM.
CM, okay. A request from the audience to participate. If any questions are there, just let us know. We can ask directly to the surgeon. We have 2 mics here. If anyone would like to ask a question directly to the surgeon, can ask.
If at all needed, the third pin can be put here to increase the visualization of the acetabulum. So now we are going to start with the reamer. So we are almost planning the first reamer. 40.
What is the size of the first reamer?
40.
40. Okay.
40, yes. So we are going to just explore first the medial wall. We don't want to go for directly in this case with a simple case like a anatomical reaming position, like proper abduction and anteversion. We just try to see the medial wall first. So deepening is done. I think we have reached to the deepest portion of the acetabulum. Now we are going to remove this. We don't need this. So we are going to do the reaming further sequential in a 2 millimeter increment with the direction of the anatomical position we try to reach. This is abduction and anteversion. This is 2 deformed socket. So we will just position primarily with
Dr. Shukla, can you show us the limb position? Your assistant limb position. What is the position? Is it 90 degrees, 45 degrees? What is the position? And what is the position of your reamer?
Yeah, okay. So I will just try to, this is my 0 degree, you can say. This is 0 degree. Okay. And this is what is anteversion, what we call, this is a retroversion. So this is almost 0 neutral position. And then you just put with anteversion. This is abduction angle, more open, and this is going to be more close. So we are just going almost in anatomical position to see what is happening inside, because there are no absolute landmarks available in this case. Okay. So we just have to follow more kind of an insight of a surgeon rather than anything else, because whatever we just talk about, like the pelvic position, dead lateral, varies as per the flexion and position of the femur as well. So actually acetabulum is a floating object in a universe. So position is important, but dead lateral position is not going to always give you a position. Fortunately, this patient is very thin limb patient. So we are okay with that. Next.
Your video is paused again.
So we have reached to 46. This is 46. We are just widening the narrow acetabulum. You have to focus here. This is not visible.
Can I ask a question, sir?
Yeah, sorry.
Okay, Dr. Shukla, thank you. So, what is the risk of putting pressure on the sciatic nerve by using the pin, inserting it constantly, or do you put it just in front of the short rotators, or don't you think that there will be a risk while you are using the pin constantly as a retractor?
Yeah.
Thank you.
Yeah, Dr. Shukla, can you hear the question from the audience?
No, I could not hear. I can hear
Yeah.
your voice very well.
Yeah, the question was the pin, the second pin, the placed near the very close to the rotators. Do you think that it is a risk to the sciatic nerve?
Not in all cases, but if it is a too stiff hip, too shallow sciatic nerve, you can just start to explore. You can just feel. You don't need to expose the sciatic nerve, but you can always feel the sciatic nerve at the back. At that time, keep your femur, means your whole leg in extension. If you flex, the sciatic nerve will always come near to the acetabulum. Keep it extension. You can bend your knee 90 degrees to relieve the stress on the sciatic nerve, and then you can always put a pin. And if there is any risk, you can avoid that pin as well. Or you can just start taking stay suture into the rotators. You retract the rotators at the back. Use some kind of smooth periosteum on the posterior wall, and then you can just put a pin under your absolute observation.
Yeah. Yes. Second thing is you have already released the gluteus maximus incision where
no, we have not released.
Yeah, because in any chronic cases or any tight thing, if you release, there will be less risk on the pressure on the sciatic nerve.
Yes, it can be released. It can be released,
yes.
And that will definitely give a better room and to play around the hip very easily.
Yes. Your video is getting paused actually. Are you able to hear us?
Yes, we can hear you very well.
Yeah, we can't see the video. So what is the size of the cup? Sorry, the reamer you have last reamed?
40.
46.
46. 50, sorry. This is 50.
50.
46 was there. This is 50.
Okay.
I think we are good with the bone inside the socket. Please give a nibbler.
So you will go with 50 cup or?
Let's use the trial now. This is the time to use the trial. We may put biprong inferior spike. More, please.
What is your advice to the colleagues, like junior colleagues who are starting with, uncimented? Your trial reamer is around 50. You place 50 or the higher size?
I think this most important thing is the bone and the bearing you are planning at the end. So like suppose a 25 or 30-year male patient, I'm planning to put a ceramic on ceramic. It's a hard bearing. So just let me finish this and I will come back with this.
Okay.
This is a trial.
We can't see your video.
This angle is video.
No, we can't see the video yet. Just before placing the cup, just hold on. Just we need to see. They're asking us to wait for 1 minute.
Yes.
Yeah.
Sir, I have a question.
Yeah, there is one more question, please.
As there is a lot of osteophytes in the acetabulum, so, sir, what do you prefer, reaming from behind or from front? That means surgeon should be in front of the patient to get better visualization and angle.
So you mean the position of the reamer you're asking?
Yeah, the position of surgeon while reaming. So
yeah, Dr. Shukla.
Yes.
Yeah, see, as there is one more doubt from the audience. You're standing, away from the acetabulum reaming. Do you like to have a preference from this, reaming from the straight, opposite side and ream, or you're comfortable with? What do you think?
Yes, that is very important question, and I think the dexterity has an important role in total hip replacement.
Yes.
I am a left-handed surgeon, and this is a left hip. So here the acetabulum, I am more comfortable when I'm operating a left hip. So as he rightly mentioned, if I'm operating in the right hip, being a lefty surgeon, It would be good if I go on the opposite side, have a better visualization, and I can use the hip. I think that is very case specific and your orientation specific. Initially, a few cases I used to do like this, and sometime in very obese, short stature female patient, we used to do this. But otherwise, I used to stand on the same side and put my cup now, whether it's a left hip or right hip. But it's a very good idea. And I think that is a place where you can see the best review of the acetabulum when you go on the opposite side of a patient, and you can see visualize your acetabulum, and you can play with it starting from reamer there, put your original cup, trials, anything from that side.
Yeah, thank
Sir,
you.
Another question is that.
Yeah, there is one more question. Can you raise your hand?
Yes.
Yeah, okay. Yeah.
So, removal of the overhang osteophytes is, do you prefer fast or to reaming fast?
Again, that varies very much on the case. If there is a very specific few osteophyte which is going to affect my cup or preparation position, then like a very dense superior osteophyte, then I would try to take part of the superior osteophyte. But to begin with, I would not like to remove all the osteophytes because I need a bone to put my cup. I don't know what will happen if we remove the inadvertent osteophytes. There may be a compromise situation. You can always do later on. But again, that varies from surgeon to surgeon and preference they can use. They can start with removal of some osteophyte and try to identify more landmarks, and then you can put start reaming, and then you can put your original cup and remove the osteophytes. Osteophytes is better to be removed with the trial in rather than the original cup. So put your trial in, and then this is what exactly we have kept a trial now, and we can see what osteophytes we are going to have all around the hip.
Okay. You already placed the cup?
No, we have a trial in now.
Your trial now. Okay. It's a 50. Is it 50 cup, Dr. Shukla?
Yes, 50 trial in.
Okay.
Bipron.
Can you zoom in or you change your surgeon's camera to show the
Yes.
cup position? Because there is a valid doubt from the audience, the osteophyte, because the inferior osteophytes is coming in between.
Yes.
So always it's better to remove the osteophytes later after placing the cup, and after the trial, if there is any impingement, you can remove.
So I think now you can easily see everything. This is a big inferior osteophyte. Now you can see this is the, you can put this direction. This is anterior inferior osteophyte. This is pure inferior osteophyte, and this is a big posterior osteophyte. Superiorly, we are okay with the bony margin, but posteriorly, inferiorly, and antero-inferiorly, there are big osteophytes all around here in the acetabular trial. So we will try to remove this. The socket trial is bottom out, and we will try to remove everything which is more. You have to take it now. Sure, please. So this is the posterior margin. You have to keep it little distant. So you can see this one osteophyte, that is a posterior inferior osteophyte that has come out. I think this can cause a lot of impingement to the neck. So this is one. I'm very happy with this. Out spike. If you have like this, out more angle. So that would be easy for visualization. And now you can see this is another section, please. This is again a very big inferior osteophyte here, and that was very well appreciated on X-ray as well. So we're going to take that one as well.
Dr. Shukla, do you ever take the inferior osteophyte earlier to expose the TAL? So you can use that as a guide?
There is no absolute visibility of tail here. I think it is entrapped into the osteophytes here. This is inferior osteophyte. Let me see if we can find tail somewhere here, which is its position. So this is loose anteriorly, and this has also come out. Section, please.
Because often you can just use your first reamer to ream that inferior osteophyte, and that will expose the fibers.
Yes, that is also a wonderful idea. That is a good step to do that. So take your inferior osteophytes out, try to explore the tail, and then put your first reamer in. So we have now good removal of inferior osteophytes here, and superiorly we are good. Posterior-superiorly, we are good. There is a mild osteophyte nibble, please. And we can just take away some bone here. I think that will do. We don't want to do much here posteriorly. The quality of bone is really good. I think we are very happy. I can leave this trial here and use this as for trial cup, as a trial cup, put trial liner. But I think we are not going to face much problem. We don't have that much time, I think. So I will remove this and we will put the original cup as well. This is quite good, not moving. So this is stable. If it is not like this in all the case, it is not mandatory to get this kind of fit and fill with the trial. You are not able to rotate this trial inside the cup. If it is well fixed, that's good, because anyway we are going to have a coating on this. So we are planning now 50 cup.
You're going for a routine cup or any other cup?
Routine cup,
Routine
3
cup.
hole.
Okay.
What is your view about irrigating acetabulum? You should give a wash at this time, or the wash should not be used? Professor David, I would like to hear from you.
When I was training, we never used to wash at this stage, but I have to admit, I wash everything nowadays. I'm very keen on basically diluting everything that's in there and getting rid of any pollution before I put the cup in.
Yeah. When you're replacing a cemented cup, definitely.
Yes, for sure, cemented. You need absolutely dry.
You're absolutely thing, but uncemented, it's okay. But you should have one wash and place it, hit it hard.
For surgeons who are having some problem with the retraction, there is one suggestion that I have learned. You can use saline on this cup. So when you are putting in, your tissues will not get catched on the cup. So that can be used. It is an optional. This is what we use sometime when there is a tissue retraction issue in a very stiff hip. So there is just a saline irrigation on the cup can be used if it is optimal. These are the 3 holes. So we have kept it superior because if at all we can demonstrate the screw, I don't think it is needed. And if you are okay with that, absolutely happy, you can rotate the cup, use the maximum surface for the osteointegration and leave the screw holes inferiorly. So this is superiorly your planned screw position. Trajectories are here. So we'll use this in this case. So we may plan to put screws if time permits us, so we can show that. So again, in the same position where we have done our reaming. Okay, bottom out. We are very happy with the cup. I would like to put 1 or 2 screws just for the sake of demonstration, but I think the camera is not allowing it that to be seen. I think we need some very different angle from the opposite side so that only we can see. You have to come here, I think, and then only it is going to see the acetabulum, the screw placement. Yes. This is better. This is still better. Not that good, but still better. So there are 3 holes where you can plan. This is, remove this. We don't need this. This is a central placement of your screw where you can put. I think there may be a cyst or something. The bone is not that strong here. But okay, then in the depth, this can be the longest screw you can plan to put, like 35, 40, 45, up to your imagination and your views. So this is a very strong bone between 2 cortexes. We may go for 35. I do have one more question for Dr. David. Does it make any difference if we have a possibility to put the screw here like 25, 30, 35, 40? Does that any difference, or the pros and cons between putting the longer screws and the standard 25 or 30 screws?
I think it depends on the bone quality. I try to use the shortest screw that gives the best grip. Normally that's between 25 and 35.
Okay. We need to fix this proper. Okay. Why this is so? It is loose. Okay, I'm done. I'm fine. Do we need to hear the sound we always get when you put a very good screw? There is always a sound between two metals like this.
The squeak at the end.
Yes, I think that is done. So one screw is in. Now there are two options. If your first screw is in optimum position, you can decide the stronger bone anteriorly or posteriorly. These are the important thing. Anteriorly there are vessels, posteriorly there are nerves. So if you can put posteriorly, there is a good bone stock. You can put one posterior screw as a derotation screw. I think we all agree that there is no role of putting one screw. So if at all you are planning to put at least two screws, or if you are happy, you can avoid screws. So it is 25.
So Dr. Shukla, would a 50 millimeter cup be a standard size for the patients you deal with?
Pardon? I didn't get your question.
A 50 millimeter cup,
Yes.
is that a fairly standard size for the
Yes,
patients
yes,
you're
yes.
dealing with?
For male patients, we usually have 52, 54. Sometime tall male patient 56. In female, we have 44, 46, 48 as a common size.
And with a 50 millimeter cup, what are your head size options for your liners?
Yes, we will use 32 in this case.
Hello. I have a question.
We have this.
Yeah.
Yes.
Please raise your hand. Yeah. thanks.
Yeah. Thank you. What are some of the reasons why the screws don't flush? Like when you're putting a screw and you struggle to have it to flush flat down. What are some of the reasons for you to correct so you don't get that problem? Thank you.
Yeah. Dr. Shukla, can you hear the question?
Yes, sometimes there is a problem in setting down the screws properly. That was the question, I think.
Yeah. So sometimes what happens is if your screw is a little bit proud, your
Yes,
liner
because it is,
won't sit.
if
That's what the
it
question
is
is. So,
not in the trajectory it is designed to be introduced, your drilling is too oblique, then that is going to be a problem. It will remain proud out of your implant. So best is to revise the trajectory of screw again, because it will not allow you too much freedom. It can allow you a good freedom, but not too much, where you can just put screws in the desired direction. So you have to follow certain rules for that.
yeah, especially in osteoporotic bone, sometimes
Yes.
when you ream it, the screw wobbles inside. So that's going to happen. You should be very, very careful in reaming the porotic bones. In this case, you can get away because a strong bone and young patient, there should not be a problem here.
Okay,
We are
thank
facing
you.
a big problem here with this instrument.
Again, the major issue with this is if you're using a hard bearing.
Yes, yes,
With a
absolutely.
ceramic liner, you're going to get canting of the liner that's not going to seat properly. You can accept a slight bit of protrusion of the screw head if you're using a poly liner, though. Although preferably you shouldn't have any.
Yeah.
Again, the question which was asked is we are going to face the same problem because the trajectory is different. The instrument is not allowing me to put the screw in that. Give me this drill, please. So we are good with our trajectory, not a problem. Same size, screw is same size. No, I want curved instrument, angled. Yes. And sometimes the bone is so hard that it is sometimes difficult to put this instrument is a problem to me. We need to fix this. think we are facing a problem with the screwdriver here. Give me just straight. We can just change the screw as well. Maybe a problem with the screw head. So we can just change the screw. Let's see. These are the two screwdrivers available. Show me the one. Angled.
Oh, that is a straight one. What?
Yes,
straight
these
one.
are two screwdrivers
Yeah.
we have. So if your trajectory is straightforward, we can use this straightforward screwdriver, which is not always the case. Sometimes you are lucky enough to use this screwdriver. Most of the time you need this modular screwdriver, so you can change the direction and you can just introduce in a way, because this angle is somewhere like this. It's not always straight. It is something like this where you want to intend to put the screws.
Second thing is, can you show the handle of the screwdriver? Sometimes it's a plastic one handle. Yeah, yours is thing. Sometimes plastic handles, sometimes it may skid and will
Yes.
not allow to rotate.
My bad. Okay, sure. So now we are done with the second screw. Watch this spike. So wash please now. By prompt. So now the socket is done. We are bottom out. We are good with the screws. And the osteophytes are removed completely. Liner. Yeah. That's fine. So the liners may have an option of symmetrical and posteriorly lipped liner. Again, that is depending on the surgeon, the case, what you want to do with your overall position of your cup, range of motion, osteophytes, offsets. So anyway, this is just going to give you a more posterior coverage in a posterior approach. It is not mandatory or doesn't make any difference whether you use it. That is absolutely needed. Being a posterior surgeon, most of the surgeons love to use this, but sometimes if you put your cup in more anteversion and this liner is going to be too proud, this can also impinge. So it is not always like a thumb rule that this is absolutely needed. Symmetrical liner is equally fine if you are optimum with your cup position. But even if at the end, when you put an original cup and you are not happy, that you still feel that the anteversion can be more, it can be increased, the only way left is to put asymmetrical or curved or lip liner or a proud shoulder liner in a postero-superior area to increase your coverage for socket. So this is what exactly we will do. Okay. So we are done with that. Let's remove this. Let's remove this. Remove the pins. The second pin. And the retractor.
You're talking about the positioning of the lipped liner and where to put the optimum position.
That is depending on what exactly, like you can play these two things independently if you plan your cup to be more close, because the anatomy is not always the same. So by putting your cup, you are planning to increase your abduction angle, and your anatomy does not permit you to do a more anteversion, then you can put it posteriorly. The liner will go posteriorly, which adds stability in the posterior direction, and your cup will add stability in the superior direction. So again, there is a possibility to put them together as it is, or you can play with the system and use the liner as the better half of a socket.
Yes, I mean, in the UK just now, we used to put them superiorly, but we're actually now starting to put them more inferiorly. We're
Posterior
changing-
superiorly, posterior superior,
we're
posterior
actually-
superior.
We're putting posterior inferior now.
So now we are with the exposure of the femur. Forceps, please. So this is the intertrochanteric line. This is the piriformis fossa. This is just, you can see the piriformis fossa here. So lesser trochanter, the iliopsoas is going anterior. We have no more anterior osteophytes here. You can use a osteotome here if you want, just like in a total knee. If at all there are osteophyte, you can use osteotome like this and just release the tissues or the bone in front of your neck. That will add to the more anteversion and position of the femur. So we are good with this. Most of the time there is a bone here that you can see. You can use this again to lift the femur, not always needed. You can just flex a bit to give a better idea. So this is our femur. Most important thing is to remove this bone. This ridge of bone is very important, because otherwise you are going to put your stem in varus, or there is a chance if you increase your placement, it would be going to have a fracture of a calcar. So to begin with, we have removed less bone. If at all required, we will do this. Very important point I would like to highlight here is this corner, posteromedial corner. So if that bone is not removed, there is a possibility that you are not going to do anteversion on your femoral side. So again, just to start your first position, you can get your varus valgus position through a canal finder. On the femoral aspect, we don't have a challenge in this case. These are simple. So this is a broach. To begin with, the smallest possible broach. Now the position is very important. We'll talk about it. Zoom out, please. So we don't need anything. So still zoom out. I want this leg to be seen. This. Yes. So the easiest way for a surgeon to start with is you can just keep it 90. If possible, you can just use a 90 degree here. 90 degree is easy to assess by the eyes. If the anatomy permits you or it is flexible, then you can have more anteversion here and you can be parallel with the floor. So these are the two ways. Am I audible there?
Yeah, yeah.
Okay.
Clear and loud.
Okay. So this
There
is
is
like,
one doubt from the audience.
Okay.
Doctor want to have yeah.
Hi. On preoperative radiographs, we can see some posterior rotation of hemipelvis or left hemipelvis because of trauma, and some decreased the body offset, whole body offset. I think it's very important end of the surgery to check the total hip anteversion first, and maybe we need some increase the femoral lateral offset. Do you any choice high offset prosthesis?
yes,
now,
depending on the case, I think there are cases where you should start with the femur first actually. So when you have more challenges about the torsional aspect of femur, like a dysplastic hip or any kind of, then you can just start with the femur. So that will guide you whether you are okay with the uncemented stem or you need to go for a cemented stem, because you are not allowed to have a proper anteversion, or you are compromising your proper anteversion. You say like, it's okay, I have some anteversion, I will accept it. And then you can play with the acetabular side. You go on acetabulum side secondarily. You first start with the femur and make sure your combined anteversion remains proper, so that the femur and the acetabulum work in concert to allow dislocation as well. So that can be done for sure.
mean, I think it all comes down to your preoperative planning and templating.
Yes.
Particularly with a complex case, you have to have some idea of what you're intending to do during the course of surgery. Just a poll from the audience, hands up, who plans every single hip replacement that they do and templates every operation before they do it? That's definitely a minority.
10-15%. So in an Indian scenario, mostly we find females or shorter versions of stems. So the supplier doesn't give an adequate offset stems. So what happens is then we'll face a problem where we have a routine offset stem. So once we place a routine offset stem in a short female, what happens is the entire the horizontal and the this one is going to change. So the preoperative templating is very important. So right from the not only the femoral version torsion or this, especially we find a lot of dysplastic hips in India. So if you don't plan properly, then you'll be in trouble on table. Yeah.
And again, you have to know the relationship of the center of rotation of the femoral head to the tip of the trochanter to get both your offset and your length correct.
Yes.
Yes. So we are going to start with the first broaching. Make sure you use this regis to remove bone on the lateral side, not on the medial side. So that will help to avoid. And you can see this is loose. So this is not done. This is undersized stem, very easy to appreciate. Use the pressure or towards the GT and just try to expand your femoral canal. This is size 3. 2. This is 2. Okay, 0, 1, 2. So 4 or 5, I think, would be the size we are going to get here. I'm good. And you can see now this is just zoom out. You can just use your hand very gently and don't try to hold it. If you move this here, it should move like a single. This is the easiest way to see that you have a very good rotational stability of your broach inside the femoral canal. Because I think the maximum load comes when the patients try to stand from the sitting position. So that is the maximum torsional forces you are going to have. So we are going to keep this here. Section, please. You can just try to use it. So this is the smallest -4 head we are going to use here. Okay. Pusher, please. Remove
Here,
this.
Dr. Shukla,
Yes.
like from the center of the head to the GT,
Yes.
yeah, what is the measurement? Because we haven't, I think we missed that one. We haven't measured that one. So
Yes.
how do you check now? Because center of head to the GT.
Very honestly say, I usually don't do that thing measurements, even pre-operatively, because I think the soft tissue will allow you something to play with. Sometimes it will not allow you. So the laxity varies significantly in patients, like age, like gender. So that measurement is a guide, I think, that can help. We had explored navigation in past as well for a quite long time. And we came across these findings that there is a huge disparity that comes between the measurements we do pre-operatively on X-ray and per-operatively, because the soft tissues, contractures, the pathology, everything has a significant effect on the offsets. So So I'm just going to lose my.
Do you do in UK? The center of head to the GT, the measurement.
Yeah, we do measure it, we template it. We've actually just published a systematic review on digital templating for the femoral component. And they're normally accurate, 95% accurate to within one size. So it's certainly worth doing. The other thing you can do, if you've got a relatively normal patient's own femoral head, is put the femoral head back over, overlay it with your trial to see if it's going to be the same offset in length. In this case,
So,
not so good because the head's collapsed.
Here we have a trial head in, which is -4 here because we have kept the maximum neck section, please. And we are very happy with the position and the soft tissue tension all around the hip. So this is, now you can zoom out.
Can you show us the rotations with zoom out?
Yes.
One is
And
flexion.
you can, this is the flexion you can
Okay.
get very easily. I can just remove the retractor for a while. I think that will make sense. More, please. So you can
Complete
see
flexion.
quite good flexion and full extension as well. So no need to address anterior capsule or iliopsoas or any structure where which is tight. You try to remove it. There's no need to do that in this case. So rotations now naturally are good. And if I do this much, I would just like suction, please. This hip is not dislocating. So from here to here, in all different positions, you can check with flexion. Now it has come dislocated like this, but otherwise it is a good stability of the hip. You can have this. I can increase, if at all, if I see the soft tissue laxity by just pulling a leg gently, but it is too good here. And most important in this kind of case is overgrown of GT and the posterior osteophytes that is not removed. So that is going to be a posterior impingement here. Anterior osteophyte with the femur is going to have an anterior impingement. So for range of motion, the posterior osteophytes are important. For dislocation, anterior and anterior-inferior osteophytes are important in posterior approach. So that is very important thing at the end. If there is anything to be done now, you can still do that. So you can remove the posterior osteophyte if they are impinging on the range of motion. Because of our patients here are very keen to sit cross-legged on the top. So if you don't have a good external rotation, they are not happy at the end.
Yeah, Dr.
Stanley, please.
Shukla, Dr. Shukla, we are
Yes.
running out of time, already 20 minutes late.
Yes.
So you can go ahead with the stem fixation and 32 mm head. I think
Sure.
you had a 32 mm head -4.
Yes,
And,
-4.
And last tip for reattachment of your soft tissues, one word so that we can close the talk.
Pardon?
Reattachment of your soft tissues
Yes,
and
yes, yes.
capsule. The importance of it. Can you have a word on it, and we'll close the.
So because we have a single layer at the back of your hip exposure, we use a standard Vicryl suture material number 2. We don't use anything more than that. It is not needed. And most importantly, the superior sutures from the tip of GT to the proximal is more important because that is a window of dislocation, we can say, where you need a very good closure. Inferiorly, it's fine that to avoid the hematoma and collection of the blood. But most important, the superior sutures are, we just use 3 to 4 sutures, simple Vicryl number 2. Drain as per the case, 50% or 70% times we don't use drain if it is not that difficult. Otherwise, patients on blood thinner, obese, we use drains.
Yeah.
So you don't use transosseous sutures, you just suture the soft tissues.
Yes, transosseous. I will just demonstrate one. Give me the
Do
Vicryl, please.
transosseous.
I'll just take one and then it is OS needle we use, and I think we are very happy with that. So we initially we used to drill the trochanter with the drill bit, and then we used to take the Ethibond, little thicker sutures, but since last almost 10 years, so we just use a simple Vicryl. The OS needle is very strong and it will definitely pass from the bone. If at all required, you can use the drill holes here on this surface. 1, 2, and 3 sutures you can take from here. So that is not going to save a surgeon like this. So it is a very strong needle. Actually, you can see it comes out very easily. That's it. So this is first, and like this, you can use 3 sutures. And posteriorly, you can always palpate a sciatic nerve. And if you are still very keen to see the nerve, just a finger dissection at the back of the soft tissue, you just swipe it off and the nerve is in front of you. So if it is not mandatory in the cases, but still it can be done. Otherwise, this is a whole thick suture tissue is for closure. And finger is going to guide you that your needle should not go inside the sciatic nerve. That's it. So stay suture initially taken, it will save your time. You have this and you have stay suture here, just close it down. So the time spent before will save your time at the end. So it's either way the surgeon's choice. So stay suture initially you spend time will save your time at the end of a case.
Yeah. Thank you, Dr. Shukla. Well done, and really appreciate. Thank you.
Thank you. Thank you.
Hello.
Yeah, yeah. Sorry, one final doubt is there. Please, sir. One call, we can take it.
Yes, sure.
Dr. Shukla, you started with -4 head.
Yes.
Didn't measure the leg length. You didn't check the leg length. So
I
was
had
it,
checked.
yeah.
Actually, we are running out of time. I had checked the leg length.
Okay, you had. So, was there any need to upgrade to larger size neck? No.
No, you can play with this thing if you want to put a larger, and then you should revise osteotomy a little bit, or you can just sink your stem if permit. I think it is a young patient, male patient will not allow you to play with your system here. So we will accept -4. That's fine. If you don't want put like in ceramic, they say, especially ceramic on ceramic. So I would try to opt for the medium head in all cases. I will not opt for the extreme of the ceramic head because it won't sit properly. There are more chances that it will have means not appropriate combination. So my first goal for the COC would be to put a medium head in all the COC head. So this is a hard on soft bearing, so it's okay to use any ceramic heads. It's fine.
Thank you.
I have a question.
Yeah.
Hello.
Yeah, please.
Thank you. Are there any techniques that you would probably or tips that you could share in making reduction easy when you have a high riding femur?
Yes. So to begin with the planning, so as Dr. David rightly said, you have to plan this complex case. Your osteotomy, first of all, you can reduce your neck by cutting little low, number 1. You can play with the center of rotation by moving it little high, not significantly, but you can play 2 to 3 or 4 millimeter at max. So you can plan that and you can migrate your center of rotation on acetabular side little high. Soft tissue release is most important thing. So if there are contractures or strictures or anything on the outer table of the ilium, you try to remove that first. Then you can try to release the anterior capsule, your iliopsoas and the gluteus maximus, and the soft tissues distal on the femur, on the linea aspera as well. So whole idea is to go little high on the acetabular side, and then you can plan as much as distally on the femoral side to bring your femur down in difficult cases. And start with the smallest trial. If you are not able to use like
Yeah, Dr. Shukla.
issues to end up in a wonderful reduction at the end of a procedure.
The other problem you might find is if you used a posterior lipped liner, it can be harder to reduce the hip afterwards. So often if you use a swab around the neck of the prosthesis just to lift it over the lip, then that will solve a lot of the problems without having to do any soft tissue releases.
Yes.
The one more final word is trochanteric osteotomy is very important. You have to keep a a sort of technique if it requires for very difficult reduction. If you have an osteotomy, you can do an osteotomy, nicely expose 360 degrees of acetabulum, reattach the trochanter nicely, and it'll be easier for you, instead of struggling out. In this case, he has done very well. Though it's a difficult hip, it went on smooth in 45 minutes to 1 hour. Thank you, Shukla, and hope the patient starts walking from tomorrow.
Thank you so much. Thank you. Pleasure.
Thank you, moderators. Thank you, Dr. Karthik Shukla. I think it was indeed a very detailed explanation and approach to the complex hip. I'm sure we learned some things out of it. Let's move on to the next session. May I request the session directors, Dr. Vijay Mohan and Dr. Karthik Patel, to take ahead the next session. Those are challenges in primary THR. And may I also request the first speaker, soft tissue balancing in THA, Dr. Amrish Jha.
So let's start off with the first session of discussions, challenges in primary THR and how we face it. Let me invite Dr. Amrish Shah for his talk on soft tissue balancing in total hip replacement.
Hello, good morning, chairpersons. Good morning, faculties and delegates. So my topic is a little bit less discussed topic in hip arthroplasty. Although we come across these things very rarely, but when we stuck in operation, then sometimes we feel intraoperatively what to do next. So if you are facing this hip or this, maybe post THR, maybe dysplastic hip or failed reconstruction or osteosynthesis, then you may need further discussion. So I'm going to present on soft tissue balancing in total hip replacement. It's not total knee replacement, mind it. So our concern in total hip replacement is based on stability. The hip must be stable. Hip must have adequate ROM with a good function. And to gain these things, we need to have a good femoral offset. We need to have good soft tissue balance as well. And we should be good in components positioning. So indications in which conditions we really require or we are worried for soft tissue balancing: DDH or adult hip dysplasia. In cases of ankylosing spondylitis, neuromuscular diseases, like if you face a case of post-polio hip replacement, revision THR, and in selective muscle disbalance or muscle contracture cases, and in THR when you do it in trochanteric fractures. So in these are the scenarios where we really need to know about the soft tissue balancing. So preoperative planning is most important, as we have already discussed. So it should include assessment of the gait, the limb length discrepancy, and contractures around the hip. We should classify in which group of muscles are contracted. Important radiographic landmarks must be evaluated preoperatively. So these are the landmarks we must go through. I'm not going into details of that. And what is obligatory steps in all THR already discussed in the live surgery? We must remove the osteophytes, anterior osteophytes and posterior osteophytes. So removal of contracted joint capsule if it's at all needed, and periarticular adhesions are also important before you jump to release of the muscle contractures. Restoration of limb length is also important. Otherwise, it's difficult to know intraoperatively which muscles need to be released. And along with that, selection of component with the proper offset is important. Additional soft tissue release in some cases may be required. Intraoperatively, after replacement, if you find some muscles are contracted, there are contractures of some muscle depending on the hip pathology preoperatively. If you find there is complete incomplete extension intraoperatively, then what will you do? You have to palpate the iliopsoas tendon, and if it's found tight, it should be elongated or released. Anterior capsule, although after that, after release of iliopsoas, if it is contracted, must be released, or sometimes you have to excise it. If the abduction and external rotation is limited, then you have to release the tensor fascia lata distally from the gluteus medius aponeurosis. In case sometimes we find after releasing of soft tissue around hip, the knee is still having limited flexion. In that case, you have to go up and then release rectus and sartorius, because these are the muscles which cross the knee and hip both. So they must be released. If there is still limitation of range of movement, then an implant with proper offset must be selected. If the limb length is correct, but the greater trochanter is still close to the pelvis, you have to choose either to increase length or to perform distal to bring the trochanter distally by osteotomy. It's important, last but not the least, wound closure is also important, as discussed in live surgery. Usually we ignore wound closure because surgeons, once we finish THR, we give rest of the things to our assistant and we ignore this, but it's important also. Try to preserve as much as capsule during your dissection and close it tightly superiorly, because in most of the cases dislocations are through the superior rent. So superior capsule must be closed meticulously, and the suture, your tensor fascia lata or your soft tissue should be closed proximally tightly, and it should be secured. So our condition, adult hip dysplasia, is the most critical scenario where we need soft tissue balancing. So I'm going into that. So according to Crow classification and Hartfeld Kids classification, these are the things we should know before we plan for ADH cases. Release in Crow 1 to Crow 4. In Crow 1 and Crow 2, it's not very difficult to reduce the femoral head because it's attached with this just above the actual acetabulum, and there is no false acetabulum. So very minimal soft tissue release is needed. In type 3 and type 4, the femoral head are really difficult to reduce, and extensive periacetabular soft tissue release is important. The 4 sequential step which I prefer is, firstly, I release the adductors and part of the iliotibial bands are split, and superior attachment of gluteus maximus from the iliac crest is released. Second, if reduction remains still difficult, the attachment of iliopsoas muscle from LT and rectus femoris and sartorius from iliac crest should be released. And even after that, if you find difficulties, piriformis and hamstring muscles, sometimes it's actually not so frequent, but sometimes you have to release hamstrings, gracilis and biceps femoris as well from posteriorly from the ischial tuberosity. And sometimes, as I said, you may need trochanteric flip osteotomy. And what about the result in ASD? Outcomes for 1 and 2 categories of patients, they are as good as primary THR, but in grade 3 and grade 4, the revision rates are much, much higher than the primary THR. So this was a case of ADH and done very nicely with maintaining the principle. This is the post-operative picture. It's a long-standing case of flexor abductor contracture, which I got very recently. So this left hand side, the patient is standing with the, you can very well appreciate that there is abductor and flexor contracture of the hip as well as flexor contracture of the knee. So this was the X-ray. We are focusing on left side. Along with that, I have put an X-ray of cervical spine, which is also stiff, and patient had a difficult intubation or general anesthesia. Intraoperatively, after I performed THR, I found that the iliac crest group of muscles like iliotibial band and rectus femoris, sartorius, all were contracted, and I had to release it. Already I released the anterior capsule. I released iliopsoas, and then I went up and released the muscles from the iliac crest. And even after that, it was not coming completely to the normal range of movement. So I had to release adductors also. So this was the preoperative picture. This was right hand side is the intra of stability. It was 90-degree external rotation, and the prosthesis was stable. But see what is the X-ray. So you can jolly well appreciate that the X-ray doesn't look so nice because the center of rotation of hip is slightly migrated proximally, and I think neck length is slightly, it should not be, it is slightly larger because the cup is slightly higher, but the stability is good. So I think in such cases, we can get this type of post-operative X-ray, but the main thing is intraoperative stability and the post-operative function. So don't worry about the X-rays only. So what about post-THR? Sometimes in primary THR, you may find patient is having hip pain. If it's around the trochanter, maybe due to gluteus medius contracture. You have performed THR and post-operatively, you find the patient is having hip pain around the trochanter. So you must think about gluteus medius contracture. If it's groin pain, you must think about iliopsoas contracture. Sometimes patient also complain about knee pain after THR. So sometimes it may be due to contracture of iliotibial tract when the pain is over the lateral aspect, and anterior knee pain if it may be due to contracture of rectus femoris. So what should we do in these cases? So important take-home message is to get proper pain-free, fully mobile joint. We should go in again. We have to go and revise our soft tissues also. That this is important. The revision is not needed for only our hardware complications or hardware problems. We should go in and revise our soft tissue contractures also. That is the theme of the lecture. Thank you.
Yes, next speaker is THR in super obese and the complication associated with it, Dr. Saurav Nanda.
Was not working.
Yeah, good morning, everyone. So in next 8 minutes, I will discuss about total hip replacement in super obese. If you see the epidemiology, we don't have any clear-cut idea about the Indian population. In US, approximately 37% of the adults are obese and 17% of the youth are obese. And since 1960, the obesity has risen 34%, and the morbid obesity is increased up to 6-fold. If the prevalence continues in the same trend, by 2030, almost half of the world population will be overweight or obese, and that are great numbers. So I think all of us know the WHO criteria, WHO classification of the obesity. The normal BMI should be 19.5 to 24.9. So in India, it should be 19.5 to 23.5. Overweight is from 25 to 30. Class 1 obesity is 30 to 35. Class 2 is 35 to 40. And class 3 is more than 40. So if the BMI is more than 40, we can call it as a morbid obesity. And if it is more than 50, then we can call it is a super obese. So we need a proper pre-operative consideration before going total hip replacement in obese patient. Ideally, we should defer the patient. We should advise the patient for bariatric surgery before doing total hip or total knee. At least we should give 6 weeks to 3 months duration, 3 months gap before performing our orthopedic surgeries. But in case of urgency or emergency like neck of femur fracture, we may go straight forward. We may need to do total hip in obese patients. But we need to we need to focus the preoperative consideration like diabetes, sleep apnea, cardiopulmonary complications, thromboembolism, infection and dislocation, which will get higher percentage of patient in obesity. So diabetes, so if the patient is more than, the BMI of the patient is more than 40, the complications rate is as high as 74 to 85%. And there is high rate of infection also in this patient. The 10-year survivorship is 85%. So we have to find out and diagnose the sleep apnea. If the patient is often snoring, often feeling tired, observed apnea, high blood pressure, BMI greater than 35, age greater than 50, neck circumference greater than 16 inches, and male gender. So we should be cautious while doing a total hip in such patients. Infection rate is higher and it is around, it is more than 9 times more in obese patient in comparison to non-obese patient. And the deep periprosthetic joint infection is 1.5 times higher in obese patients in comparison to non-obese patient, resulting in high rate of revision. In obese patient, because of the fat necrosis, there may be chance of hematoma formation, which may result in more infection in case that we found in the obese patient. Dislocation rate is also higher in the obese patient. In every 10 points rise in the BMI, there is the chance of dislocation is 113%. The dislocation mostly because of the 3 factors. Number 1 is because of the high weight. If there is any twist injury, the torque that is experienced in the hip joint is more. Number 2, there is high fat and low muscle mass. The muscle actually prevents the dislocation. If the muscle mass is low, then there is more chance of dislocation. And third, the most important factor is the surgeon's factor. If the inclination of the cuff is more, then there is chance of more dislocation. Intraoperatively, while we are doing reaming, we need to keep remember that in the lateral position, there is already 9 degrees of pelvic adduction. So if you want to achieve the 40 to 45 degree true operative inclination, we should ream around 35 degree in the angle of the 35 degree. If we ream at an angle 45 degree, then we will get the true operative inclination around 54 degree. And in obese patient, if this is the incision, if this is the surgical exposure for lean and thin patient, but this will be the skin length, the level of the skin will be in the higher position in case of obese patient. And if we are not, the exposure is less, exposure is limited, and if we do the same type of exposure that we used to do for lean and thin patient, then the reamer will go in a wrong way and there will be intraoperatively misjudgment, and we will get a cup position in which the inclination will be more and the chance of dislocation is more. So we need to expose more so that our reamer will accommodate in a proper position so that we can get the right inclination intraoperatively. I'm sharing a case with you. So here is a 69 years old female, weight 140 kg with BMI 62.2 kg. Sorry, 62.2. So she comes under super obese category. Luckily, she was not diabetic. She was but hypertensive and under medications. She had a fall in bathroom, and she had neck of femur fracture. She was operated with total hip replacement. She was fine. The surgery was done in 2017. So she followed off on 2018, but in 2020 she had twist and domestic fall in January 2020, and the hip was dislocated. The index surgeon again tried to close reduction, and he achieved close reduction of the hip joint. So this thing in January 2020. In March 2020, again there is dislocation, and again the index surgeon tried to reduce the hip joint. But again in Jan 2021, again there was dislocation, and the patient presented to us in this stage. We did a CT scan of the pelvis with hip, and we found that both the acetabular component and the femoral components, they were well fixed. The anteversion of the acetabular component was fine, but the inclination was around 54 degrees. So you can see the inclination is more in this patient. So we thought to revise the acetabular side. Intraoperatively, there was some challenges. We need to take out the cuff, and we planned for either constrained hip or dual mobile hip. And if the bone stuck, we cannot able to get the good bone stuck. So we kept the cage also ready in the table. So there are challenges of anesthesia, positioning of the positioning and preparation of the patient, intraoperative finding of the landmarks, and perioperative and immediate complications of infection and dislocation. Actually, 2 OT tables we combined to provide a proper room for the patient, the super obese patient. So at that time, the COVID was at its peak. We struggled for all logistic thing like constrained hip, dual mobile hip, and the implant extractor system. IVC filter was put to avoid any thromboembolic complications. This is one of the important things in super obese patient. We need to see if there is any thromboembolic complications we're expecting. So better to put a IVC filter. Anyway, we can able to take the implant out from the acetabular side with there was no gross bone loss. The bone stock was good. We use this instrument. Yeah, so this special instrument. So that cuts only the periphery portion of the implant. Okay, and finally, we able to put a dual mobile cuff, which was stable enough, and the mountain was set in motion once again. So the summary is, in obese patient, we need to plan preoperatively so that intraoperative and postoperative complications will be less. The exposure should be more so that the inclination while putting the cuff, we can able to put the cuff in a proper right position. We should use drain, and we should give postoperative blood thinners like low molecular heparin or rivaroxaban. Okay, thank you for your observation. Thank you.
Thank you, Dr. Saurabh.
Yeah.
Next, may I invite Dr. Vaibhav for his talk on THR and dysplasia. And one more request to all speakers, since we have a long day to go, please stick to the time.
Hello. Good morning to all. At the very outset, let me thank Meryl and the organizers for having me here for the 15th master course. Okay. Okay, fair enough. So today I'm going to talk about dysplastic hips and the total hip replacement. It's one of the topics which I feel needs a lot of attention, and we need to be very careful while doing this. We all know that DDH is a spectrum of conditions which is congenital, and the probability and the rate of developing arthritis depends on the severity with which the patient has a DDH, but eventual treatment is going to be arthroplasty. We all are aware of these sharps angle, and then we know that this angulation is very important while doing a total hip replacement and also while leading with the dysplastic hips. The normal being around 33 to 38 degrees that we need to get it. The lateral center edge angle of Weiberg is again very important, which is normal around 15 degrees and more. In moderate dysplasia, we have an angle of around 5 to 15 degrees. And in severe dysplastic cases, we have less than 5 degrees of angle. The aim in dysplastic hip is to have a mechanically as well as biologically sound total hip replacement with anatomical restoration of the center of rotation of the hip. That's what the aim is going to be in dysplastic hips. The principles of THR are going to be the same, whether it is related to the inclination, the depth, the height, or it is leading to the medial or the vertical offsets. The principles of THR would remain the same. The only thing in dysplastic hip is what we need to know, that the abductors are short and contracted, and that is one thing which you need to take care while doing a dysplastic hips. So if you take in totality about the dysplasia, what are the problems that we are going to face in dysplasia is that the acetabulum is very shallow, it's underdeveloped, and the version of the acetabulum is going to be different. There is going to be a bone stock which is going to be poor, and the anterior column in these cases is going to be very thin as compared to the posterior. The posterior ones are the thick ones. And the anteroposterior diameter of the acetabulum is going to be smaller. That is something which we need to know for sure. And the acetabulum is going to be deficient superolaterally and anteriorly. Vis-a-vis, if you see the femur, what are the general problems that we are going to see? We're going to have increased anteversion. The neck is going to be short. You may have a narrow and a bowing of the femoral canal, which again you have to take care. There can be an elliptical femoral head and an incongruent hip, which you're going to get. And the head is going to be deformed and small. And apart from all this, the patient is going to present with the limb length discrepancy, the limp. As mentioned, the abductors and the flexors are going to be shortened. The psoas adductors are going to be contracted. The capsule is going to be stretched and elongated. And there is always a chance that you may damage the sciatic nerve or the femoral vessels. This is something which everyone should know. Earlier, we used to talk about Crow classification and then the management in Crow classification accordingly. Heart of Phylacteries has devised a classification in which we have a type A, B, and C. The type A being a dysplastic hip, the type B being a low dislocation type of hips, and type C, which is the high dislocation types. So these are the typical X-rays which you will see. The one on the left is the type A. The second one is the type B with a false acetabulum which is formed, and type C is the one which is riding very high. So these are the three kinds of cases that you're going to get in dysplastic hips. That's the Crow classification. So typically the normal, the 1 and 2, the 3 and the 4, the fourth being the high dislocation types. So I'll just run through this: Crow 1, Crow 2, 3, and Crow 4. I feel total hip replacement, all cases need to be planned for sure. There is no second thought about it. But in dysplastic hips, you need to plan it much more, because these are those complex cases in which your femoral canal is going to be very small. The size of the femur is going to be very small. Also, you may have to decide about the neck cut, because sometimes it can be high riding and your neck cut might have to be managed accordingly. Similarly, your acetabulum, which is there, they are generally very, very small, and you need to know what you're going to put to get the center of rotation back to normal. So these are the typical lines which I guess we all of us draw preoperatively to find out what is the limb length discrepancy, what's the inclination that you're going to put in, and what are the deficiencies of the bone that you're going to come across while dealing these cases. As far as the implant selection is concerned, it all depends on the age, the bone quality, the availability of implant in a particular city or a country, and surgeon's experience about cemented versus uncemented. But take my word, anything and everything which is there should be available in the theater when you're doing a dysplastic hip. The choice would generally be an uncemented cup for a acetabulum, and the smaller diameters need to be kept. So you need to tell your company guys typically, because they would keep it 42 and beyond, but ask them to keep a 38 and a 40. A few of the companies have come up with a 36 cup, but 38 and 40 is something which is very, very commonly used in dysplastic hips. So please tell your company guys to keep them ready. And of course, when you're putting such smaller cups, you need to put in 22 millimeter heads, which again need to be there in your armamentarium. As far as approach is concerned, for type A and type B, it does not matter. You can do whichever one you're comfortable with. I use a direct lateral hard hinge approach for type A and type B. But for type C, I use a posterior lateral approach because if you have to do a subtrochanteric osteotomy, then that's the way to go. Okay, and sometimes you may need to have a combined approach. So tricks of the trade for all this, we are going to discuss it when we are trying to do it, but these are generally the tricks of trade while doing it. The subluxation types or the type A dysplastic ones are the easier ones to do. They're almost like a standard hip replacements that you're doing. But so that's not much of a problem, except for medialization of the acetabulum. You don't need to do much about it. Rest all comes back into place. For the low dislocation types, you may need to do certain things vis-a-vis the high dislocation, which will come in sometime. These are the different kinds of reconstruction, which again, I'll not go through because you don't need all of these. Let's get on to the dysplasia type A, where the femoral head is contained with some degree of subluxation, which is there. I think the morning case, which is there, we had a medial osteophytes and there was a subluxation. So there was a question which was asked as to why, whether to, like we have a protrusion, whether we should call it something else. It's just a simple subluxation of the hip which was occurring. And that's why the horizontal offset was very high in the case which was done in the morning. So once you try to medialize your acetabulum and you get your stem back, your horizontal offset is going to reduce, and then the center of rotation will be normal. So coming back to this, the acetabulum is very shallow with the medial osteophytes in a dysplastic hips. So you need to know about that. And there is a segmental deficiency. So first and foremost, like any hip replacement, you should locate the true acetabulum. The true acetabulum, the fat, the tal, fat pad sign, tal is always going to be there. So locate that, clear the floor osteophytes which are there, and just medialize the cup. Once you medialize the cup to the true floor, you have their problems as a result. Do not over-ream it, because your anterior bone, you have to realize that your anterior wall is very, very thin. So don't try to over-ream or try to put a bigger cup. Just try to palpate your anterior wall, which is there, which is thin, and check again onto the posterior. While reaming, also try to err more on the posterior side as compared to the anterior side. And try not to expose your anterior shell anteriorly, because it may irritate the psoas. That's a standard type A dysplastic hip which has been done. In a low dislocation, what is happening is that the femoral head articulates with a false acetabulum, and there is a deficient superior wall. There is anterior posterior segmental deficiencies, and as usual, the acetabulum is shallow and narrow. Again, the same thing, you need to locate the true acetabulum first. So get your fat pad, tal, it's always going to be there no matter what the hip is. These two are the ones which will always be there. Start with your smaller reamers and medialize. In cases of type B, what is going to happen is you're not going to get 100% coverage. But even if you get 70 to 80% coverage of the shell, it is fine. Anything less than 70, reaching 60% of the coverage of the shell, then you need to change over to the cemented cup, which is there. The superolateral grafts can be structural or non-structural, depending on what is the deficiency, and use a human. So this is just a thing to show that when you have a femoral head which is articulating superiorly and you have a defect there, you can put in your cup and the defect can be covered with either the spongioplasty or the structural allograft. Either of the two can be used. That's the one where you can see that the graft has been put superiorly. Similarly, these are the structural allografts which are been put on either side. So we fixed it with 2 screws and a structural allograft, and that has been done. Similarly, again, with one of the screws, the structural allograft has been used. If you don't want to use the grafts, then you have now options of tantalum. So you can use tantalum wedges, cups, and all these things. So one of the options is to use the tantalum so that you can cover your defect, which is there. This is a case in which a tantalum has been used onto the left side and an SROM stem. So as I was talking about, if you're doing your acetabulum and the coverage is 70 to 80%, you can still go ahead and do the uncemented cup. But if the coverage is not 70%, if it is less than 60%, then I resort to a cemented cup where we put in a bone graft and a mesh, build up the acetabulum, and then do the cemented cups. Sometimes the defect is so much that you're not able to even put that. And in such scenarios, you may need or resort to the cage and go into a cup cage concept where your cup has to be cemented to the cage. This is one of the cases in which, if you see, there was a huge deficiency which was put in with the bone graft, fixed it with the cage, and then a cemented cup has been used to restore it back. Type C are the high dislocations, one in which there is varying degrees of superior migration. There's a segmental deficiency. There is a narrow acetabulum, excessive antiversion, and everything remains the same. The technique, as I said, that because if you're doing a subtrochanteric osteotomy, then rather than going by direct lateral hard hinge, I took a posterior approach. I excise the elongated capsule, stretched capsule, which is there. And that capsule itself leads you to the true acetabulum, where you can then find your fat pad and the tal. For the acetabulum, you start with the small reamers directed posterior superiorly. And as in all the cases of dysplastic hips, try to medialize your cup, cortiloplasty if needed. And cup size, you have to remember one thing, that's why it is written in red, is by AP diameter. So when you try to do an acetabulum in a dysplastic hip, you always feel that superiorly there is some kind of more space which is remaining, and you try to rim it more and more. You have to remember that it's the anteroposterior dimensions, and the anterior wall is extremely thin. So do not try to put in or rim too much. Just try to check the thickness of the anterior wall in dysplastic cases. Femoral versions can be adjusted by taking a lower neck cut so that you have a little bit of toggle effect which is there. And in the cemented cases, you can put in a smaller stem so that you can change the version in case if you need by creating more space. You can have a modular stem like a SROM stem where you can easily dial it to the desired version that you want to, and you can use an uncemented stem. Or you can use a cemented straight or the regular stem, but a smaller size than what you're using so that you can change the version which is there. Various things which can be done in femur by doing osteotomies, but in severe cases, subtrochanteric osteotomy still stands gold standard. It's a reduction subtrochanteric osteotomy wherein your uncemented stem has to be first put into the proximal part of the femur, get it back, reduce it to the acetabulum, and then try and match it with your femur. And whatever is an excessive bone, you just excise it and then put it distally, which is there. So that's what you're going to do, and then fix it with the cables or plates or whatever that you need to stabilize it more. So that's the subtrochanteric osteotomy advantages. Although you can do trochanteric osteotomies, there are lesser trochanteric osteotomies, greater trochanteric osteotomies, but this is one of the advantages that it is the best to correct the deformities. It is excellent. It gives you an excellent acetabulum exposure. Once you do a subtrochanteric osteotomy, you can see the acetabulum straight in front of you. The rotation of hip center and offsets can be managed very easily with the subtrochanteric osteotomy. And there is no greater trochanter which needs to be fixed and leading to non-union and breakages of implants and other things. But yes, subtrochanteric osteotomy is complex. Non-union potential is always going to be there. It takes longer time for the recovery because your osteotomy has to heal. And in younger patients, generally, it is better to do them. Implant selection, you have plenty. As I told you, keep anything and everything in your armamentarium whenever a cemented, uncemented, wire, cables, plates, everything, because you never know what you're going to require. That's one of the dislocations which are there, which is used SROM stem and a standard cup. You can get there's a medialization of the cup, and then the cup is sitting straight at the teardrop. This is again type 4. What we have done here in this case is, if you see that the neck cut is just above the lesser trochanter. So we have cut more of the lesser and try to put in the stem without doing a subtrochanteric osteotomy. This is a bilateral type 4 where we have to do bilateral subtrochanteric osteotomies where we have got, you see the size of the acetabular shells. It's so small. This is a 38 size which you put, and a solution stem along with to fix the subtrochanteric osteotomy that has been done. Very rarely, sometimes if you're not able to get it down and you're in trouble and you don't know what to do, sometimes, now I have stopped this. These are my earlier cases where probably a higher hip center has been accepted, but higher hip centers would always lead with patients being unhappy because they will have lurch, they will have limb length discrepancy, and they're not going to be happy. So these high hip centers, although the books mention that you can accept it, but they are accepted only in rare scenarios where you're just not able to get it down and you feel that the sciatic nerve is at stake. So if you see the take home message, you understand the dysplasias, whether it is dysplasia alone, it's low dislocation or high dislocation. Contractures have to be released. So a wonderful lecture was given on soft tissue contractures and the release is just prior to me. Adductor tenotomy may be needed. The acetabular reaming, you have to understand that acetabulum is thin anteriorly and sizing is done by AP dimensions. So don't take superior inferiorly. The femoral anteversion needs to be corrected. There are various bone grafting techniques that you need to do and the osteotomies that you need to be aware. This is like a chart in which we have said that Crow type 1, type 2, 3, and 4, and what exactly needs to be done and what kind of implants that you would use it. And this would definitely help. Thank you so much.
Thank you. Since we are running late, we are not having a proper tea break. So we are continuing with the next session, but tea and some traditional delicacies are like running on the back. So anytime you're free, you want to have, you can go out and have it and come back. Thank you.
Thank you, moderators, and thank you, delegates. We'll keep going as and when you feel like sipping a cup of tea, please feel free. Some local delicacies, as Dr. Vijay Mohan mentioned, they are also available. We just move on straight to the next session, which is philosophy and techniques in THR. And may I invite the session directors, Dr. Amandeep Bakshi and Dr. Vaibhav Kasodekar once again. And may I also request the first presenter. It's a video presentation on direct anterior approach by Dr. Karthik Patel.
Hello, once again. Can we have Dr. Karthik Patel to do the video presentation on direct anterior approach, please?
So,
Just till the things are settled, if I may ask, is there anyone in the audience who is doing direct anterior approach? Can you have their hands up? How many of them are doing it? Are you doing it regularly or you do it occasionally? I just saw a couple of hands going up.
Yeah, here.
Oh, okay.
Yeah,
all right.
We use a specialized table for a couple of cases, but not with a routine table, because the elevation of the femur is a little bit difficult.
So then you
these-
have an assistant who helps you out to get it
yeah,
done.
obviously, yeah. Medacta table and the other tables. Yeah,
Any specific indication why you go for anterior approach?
I'm not doing regularly, but the only thing is only primary THR. I don't do revisions in anterior, only primary THR with a specialized table. And, the females, the ideal selection is very important. If you select for revision cases or dysplastic, I think you'll be in trouble.
You've got all those spikes which are required
Yeah,
for that.
spikes and table. Actually, we bought it from Australia recently. So it requires a separate set of instrumentation. And the table also, the Medacta table.
Right.
A bit thing. But we have done a few, but it's a learning curve. At least 15 to 20 cases you have to do for doing more cases.
Right.
Yeah, why I'm here is before starting the session, the last session we want to continue regarding the dysplastic hip.
Yeah, sure.
Your topic was excellent because, but the Ranavath group has proposed like, more than a decade, 12 years follow-up of high hip center. But your contradictory is that you don't want any high hip center because it's high hip means superior and lateral migration is definitely avoided. But the high hip, whatever how many centimeters do you accept? Because sometimes on table it could be very difficult to have anatomical, position of the things.
Right.
Yeah.
So I'll tell you. So that same thing which they had presented,
Yeah.
they said that you are okay to go ahead with the high hip center. Okay, in the sense it's not normal, it's not there to accept it, but you can accept it because the results are all right. So you can accept it, but that's not ideal.
Yeah.
So as I mentioned that in case if you feel that your sciatic nerve is at stake or you feel that there is too much of soft tissue contractures and you're really not able to get it down, in those scenarios you can accept it, but you have to tell the patient that the lurch is going to be there. So patients land up with lurch and the limb length discrepancy still remains. So they either have to use in your high heel shoes, which are there, which again, they should be okay with, then it is fine. So it's not that they have dislocated or they have landed up with early loosening or anything. So they have done well.
Yeah.
But then, yes, then you have to accept these two things which are there and then go ahead with it.
Yeah. Type 3 especially could be a difficult thing compared to type 4. Whenever type 4 you do osteotomy, you get it down and release. But
Right.
type 3 should be careful. What is
Right.
that? Take home message.
Yes, yes.
Thank
Hello, good morning, everyone. So my talk is on the direct anterior approach THR. So it's not a new approach. It has been done in Europe for quite long, but they are started doing in the US and they are just coming into India. So this was the case, 75 male, right? Hip pain for 2 to 3 years, significant restricted range of motion, and this was the preoperative X-ray. So significant arthritic changes with sclerosed bone on acetabulum side and femur side as well, with quite shortening. I operated this patient with direct anterior approach without table. I do my all direct anterior approach without table, even complicated protrusion and the ankylosing hip also. And this is the video. Without table direct anterior approach requires this special retractors and the special releases, which we don't require with the table. So this is how we do painting and dripping. We paint both limbs, so we can move our operated limb in figure of 4 position below the non-operated limb. And so this part of the video to just show how we do the painting and dripping in the direct anterior approach without table. So first we mark the anterior superior iliac spine, 2 finger width below, 2 finger width lateral. We took incision around 8 to 10 centimeter. Usually GT comes in the center of the incision and the direction of incision towards the fibula head. And we keep the incision and we cut the skin subcu, and then we expose the fascia or the tensor fascia lata muscle. In direct anterior approach, we go through the tensor fascia lata. We cut here the tensor fascia lata. In classical anterior approach, we go in between the sartorius and tensor fascia lata. But in this case, you can see that we go through the tensor fascia lata, bring the muscle belly backward, and that how we expose the rectus muscle. And we can see that there is a demarcation between the lower border of the rectus, where we just open it and we find the vessel, which we call the lateral circumflex femoral artery. This vessel, this vascular bundle, we need to ligate. Either you can cauterize or you can double ligate or you clip it, because if it start bleeding, it bleed a lot. Usually I do double ligation and cut in between. And this allows us the proper retraction of the rectus anteriorly, and we can put the Charnley or retractor there. So we retract the tensor fasciae lata posteriorly and the rectus muscle anteriorly. After retracting the rectus anteriorly, we are on the anterior part of the hip capsule. So, and there is a muscle called the iliocapsularis, which is just above the anterior to the hip capsule. So, in this part, I am showing that just we are erasing the iliocapsularis muscle, and we put the spike underneath the iliocapsularis muscle over the hip capsule, so that we can protect the vessels. So one spike over the superior border of the calcar or neck, one spike inferior border of the neck outside the capsule, and one anterior acetabulum rim. So this is how we expose the acetabulum, anterior hip capsule, and we cut the. There are various methods of cutting the hip capsule. You can cut in T fashion, you can cut the straight, you can cut the Z manner. I usually cut the H first vertical limb, and then put both spike inside the capsule, give a little bit traction, and erase the capsule from both intertrochanteric region and from the acetabulum side. So we can see the anterior part of the neck and the head both. Hip anterior capsule is quite thick compared to the posterior capsule. And proper releases of it requires for the proper visualization of the acetabulum, as well as the proper elevation of the femoral shaft. Now we put the corkscrew. This is one of the thing we have to do, because we can do osteotomy in situ. First, I dislocate the femoral head so that release some tight structure automatically. So I don't need to release too much. Reduce back the femoral head. Mark osteotomy either under C-arm or as per your convenience, and do the osteotomy. With corkscrew, we can remove the head. And now we can put this kind of curved spike in the teardrop. One spike over the posterior column, which retract the shaft posteriorly. One spike anteriorly over the anterior acetabulum rim, and the one over the teardrop. And here I am releasing the inferior capsule so that I can retract the shaft more posteriorly. And the advantage of the direct anterior approach without the table is that you can prepare the femur and the acetabulum under C-arm. So it's more a navigation type of thing, where you can just confirm your feelings or your judgment with the C-arm. So in that case, it was a bit high center. So I tried to bring it down with the first rim medially toward the teardrop. And then all inclination, all versions are confirmed under the C-arm. Trial, go in and check the stability of the trial. Confirm the positioning of trial under C-arm, as well as the stability of the trial. This is the stability, the absolute stability of the trial. Trial is removed and the original shell implanted. You can put the screw if you want. You don't. I usually keep the screw holes inferiorly. I usually hold my handle and ask my assistant to hammer it, so I can properly hold the implant in correct position in which I want to implant. So that is still not bottom out, so I finally hammer it. and the cup is bottom out. Checking the stability of the original shell and the implantation of the poly. Now, most important thing is the femoral elevation, femoral preparation, for which you require the three releases. First is the pubofemoral ligament release, which allow us more external rotation. And second most is the superior capsule release. Until unless you properly release the superior capsule, your femur will not bring up. So with the hook, you can give the traction, and just traction makes the superior capsule tight. And you, with the cautery, you can start releasing from the superior border of towards the, in vertical direction, not like horizontal direction. So and put the cow spike behind the GT or the bare area, and that will bring the femoral head up like this. And this position required for the preparation of the femoral shaft. So bilateral THR is very easy in the direct entry approach. You don't need to change the position. Until unless you elevate the femur like this, you cannot prepare the femoral stem, and that might end up in the fractures and malpositioning of the component. Usually I refashion the neck cut with the calca rims. So this stem was not going, so implanted. Last size was size 3. Trialing with the head. This is the final positioning on the CM, and checking the stability in the deflection, rotations, extension, pull test, limb length. So limb length verification is very good in the direct entry approach, because you can confirm clinically as well as on the CM. This was the post-op X-ray, and this is how I learned. This is why I learned, because the learning is something what you understanding before you start understanding in a new way. So after starting a direct entry approach, I learned hip anatomy in a different way. So and still I continue to learn. Thank you everyone.
Thank you, Dr. Karthik Patel.
May we invite Dr. Uday for his talk on total hip replacement in failed intertrochanteric fractures.
Thank you, Chairman. At the onset, I thank Merrill Group and Merrill team. This is something routinely we come across our trauma colleagues. Sometimes they do excellent job, doing a replacement in a smooth way for us. But sometimes it becomes complicated when they fail, so, especially in the trochanteric fractures, because the completely shatter of the proximal femur. Nailing has been revolutionized. We are doing another 15 to 20 minutes. They're coming out in very fast. Sometimes it fails, like revision of a PFN or doing a DHS revision is much more difficult than removing a screw and doing a total hips. So we should be very careful, especially in doing a fracture fixation. Sometimes our work for the replacement surgeons become very tough. So in a total hip replacement as a salvage treatment for failed intertrochanteric fractures in elderly reduces significantly reduced hip pain and restore joint function, and early outcomes were satisfactory. So what are the challenges we face here? Routinely, what happens is in trochanteric fractures, usually they fall at home. They are usually very, very elderly. They are elderly, and they come with a severe porosis. Sometimes if that fails, either due to some surgical technique or porotic, sometimes we can't blame the surgeons. Sometimes the patient itself has a lot of risk factors. It may get failed, lost follow-up. So many things can occur. Redoing this into a conversion into a total hip is a very, very difficult challenge. Why? Because when this pictures comes to us like in top right one or in the or second one, what happens is you should always think of infection. Sometimes infection will be silent. ESR, CRPS, all our markers are normal. You should thorough workup with all your other investigations. And sometimes removal of the hardware is very difficult. You feel that doing a total hip in this sort of position is easy, but removal of hardware, sometimes you may stuck on table, and sometimes you can be a surprise on table. Second thing is bone loss. You should have adequate bone loss. Usually they have anemic, hypovolemic. They're a little bit of low volume, and we always do a serum albumin test because they are malnourished. They are elderly, not taking care properly. Soft tissues, contractures are very tight, and sometimes we find bone defects. I'll come with directly with the cases where we feel it has to be discussed more. We have a 58-year-old male, right trochanteric fractures, and he had a query history of fall, sustained maybe a neck fracture, we don't know. And he came with his known hypertensive, diabetic, and alcohol. He's on alcohol withdrawal. So he came presented to us with this picture, like it's clearly a trochanteric fracture extending just below. It's below this trochanter. The choosing of the nail is very important for the trauma colleagues. So sometimes what happens is instead of cephalomedullary, they use this type of nails where your criteria is defeated on table itself. So there's a full length X-ray. It's showing the fracture is extending well below the subtrochanter, and the nail has, it's an intramedullary nail. So it never solved the purpose. So he came with the severe pain. We have done with the CT scan, and it shows that the screws are almost in the neck, and there is an intercapsular fracture. So it's a very challenging case, and we need to explain the patients that okay, it has been long duration and more than 4 to 6 months now, and the neck fracture is walking on that, very, very painful, and this is how it comes. So we offered him direct hip replacement to have a better quality of life, because redoing this in the neck fracture 4 to 5 months later, again he comes back with the hip pain, and it's not a good suggestion. So we have done a dual mobility cup because his abductors are weak, his lurch was there. So we have done a total hip dual mobility, and with the long stem, our criteria is mainly to bypass this the fracture pattern and do a proper follow-up. So it went on healing with 8 months follow-up, and patient was doing well with a little bit of lurch is there. 8 months follow-up, he was doing well. Why we choose dual mobility is because he's a chronic alcoholic, and occasionally has this withdrawal symptoms. I don't want to take risks, so put him on a dual mobility and come out. Second case is a 62-year-old female, and right DHS operated for unstable trochanter. As you know, as the classifications are there, more unstable, better go for right nailing rather than doing a DHS. So she came with 10 months follow-up. So if you see this pre-op X-ray, so initially see the bone quality of the right and left, so how much the bone quality, because she was not walking from the time of surgery. It's almost 10 months they came to us, and the screw is completely backed off, and the bone is papery soft. Yeah, on table, you should always feel that, okay, this can have a fracture on table. You should have a good backup, and your morphology of the the proximal femur is altered. Your screws are difficult to remove. Sometimes you need to have extra instrumentation to remove all the screws. Send for suspected cultures if you have any interop. All them should be taken care. And it should be a proper planning to do this. Otherwise, what happens is you may have intrafemoral fracture, acetabulum is thinned out, nothing, walls or column, nothing is there. So you need to have a backup cups, dual mobility cups, any additional cups to have a stability on table, because this patient is in bed 10 months with a diffuse bone loss. You should have a very, very good backup. So I've done a cemented cup with the long stem, bypassing the defects. That is the main criteria to my other colleagues, junior colleagues, to have a follow-up. They have a good outcome, but the problem is since they are 10 months in bed, it takes long time to recover, maybe 8 months to 1 year to follow up. So this is I don't know, the pictures are coming rotation. She's walking 3 months post-op with a walker at home. She has pain. That's what she shows on video in that area, and she has lurch. And after a certain period of time, 8 months, she removed the walker. She is walking with a single stick. Definitely, her quality of age has improved compared to previously. As you know, the trochanteric fractures, intracapsular fractures, the mortality is very high, at least 30 to 40%. When that fails, again, they've come for revision, then it's really challenging. So you need to have a preoperative optimization for these patients to have a good outcome. Otherwise, this get infected. Third case, simple PFN, straightforward case. It got infected, unfortunately. And they came to us. They have already done somewhere with a cement spacer. Luckily, the cement, it worked. The markers were negative. And someone has done the total hip. And this is what happened. So you should always remember this X-ray for your lifetime. The main purpose why I want to show is, see the on the right first picture there. So the main concept is to bypass the last hole there. That is the main concept. To do a total hip. If you do a revision case, it comes with this. It's a horrible nightmare. The patient is disturbed. Your surgeon is disturbed. Everything is get disturbed. Doing surgeries, it's a fancy thing, but when you find a complication, again, you'll be quite distressing for you. So we need to fix with a plate, some sort of plate fixation. Luckily, it's a type Vancouver classification type, B1 type, where it's below the processes, but stem was fixed and patient was doing okay. This is the last case where a 70-year-old female sustained intertrochanteric fracture and iliac wing also, and he has pain since 3 months, but no trauma. So this is a presentation, and the straightforward case, do a nice nailing and come out. You think that you have done a good job with the iliac wing fracture, some sort of fixation there. It was doing immediate post-op, and 6 months follow-up. The screw, started backing off. Maybe not adequate compression on table. If you see on the lateral X-ray, the screw was in center, and here everything was okay. But the GT luckily got united. Iliac wing also got united. Patient lost follow-up due to COVID or other reasons, and 4 years suddenly they came with this. The proximal part completely, if you see the proximal femur is completely distorted, means it's united, but anatomy has got distorted. But he has this arthritic changes of the hip. He came to us with a severe pain. We need to do a total hip for this. I've chosen for cemented on table. See the amount of distortion of the proximal femur. So in this case, when you revise for trochanter to a trochanteric failed internal fixation to a total hip, it's a very challenging. You need to do either navigation or a proper CM or CT scans before that, and see the femoral canal and do it. Otherwise, on table you might have trouble. So this is a post-op. Luckily, he's doing well. 9 months follow-up. Of course, multiple surgeries. He has a little bit of lurch and doing well. So take-home message is very challenging to perform a total hip in a failed intertrochanteric fractures. Severe osteoporosis is the main key. You should not have any trouble on table. You should have all armamentarium on thing backup. Underlying lurking infection, whatever your microbiologist, pathologist, whatever it is there, you see that you rule out all the infection because they are quiescent. These infections are very, very quiescent. And severe bone defects, that is very important, especially on the acetabular side. You should have all backup on table. Modular implants for backup, especially long stems, are very important. You've seen that X-ray of that film. You should have, you'll never forget, always have a long stem to bypass the screw holes of the previous stems. So risk of complications are very high. You should be very careful, take an opinion of other colleagues to save your hands. That's what. Thank you.
Thank you, Dr. Uday. Can we call Dr. Vijay Mohan for presenting THR in acetabular protrusia?
Good morning, respected chairpersons and dear friends. So my topic is THR in protrusia stabile. Especially for the beginners, this can come with a set of challenges and difficulties during surgery. So, but the basic principles remain the same, like restore the biomechanics in like a normal THR. Just to brush on the memory, the first case was published in 1824. That's why like it's known as autopelvis also. And he described it as a acetabulum protrudes in the pelvis like half an orange. And earlier we thought acetabular fractures is a main reason for this protrusion. But there's a hell of a lot of reasons for this. It can be primary or secondary. It can be infectious, neoplastic, inflammatory, metabolic, or traumatic. A lot of reasons. But in practice, like we come across these two. Mainly the inflammatory, like rheumatoid arthritis or angst, or maybe the traumatic, like a sequelae of a old acetabular fracture, or a surgical error done by the surgeons. It was postulated that condition was secondary to a chondrodystrophy, where the 3 plates of the triradial cartilage remain unfused in primary. And certain amount of protrusia remains normal till 4 to 8 years, where the child has a wide base gait and varus orientation of the lower limb. And once the normal valgus orientation gets restored, the reduced distribution of stresses comes and put back to normal. And acute idiopathic chondrolysis seems to be a reason for primary protrusia stabile, because studies have shown that there's areas of focal osteonecrosis in the femoral head, as well as degenerative changes in the acetabulum in patients with idiopathic protrusia stabile. And this picture, we have been seeing this again and again from today morning, like all these lines are distorted in protrusio, like the ilioischial line and the center edge angle, and the abductor inefficiency, all those things. Like the aim of surgery is to correct all these points. And based on the protrusia, it's classified into 3, 0, 1, 2, and 4 stages, 0, 1, 2, and 3. Seems like only a theoretical importance for this, and on practically on the table, irrespective of your grading, like your aim is to get back the normal biomechanics of the hip. And I told you, like basically we see these two, either because of the bone quality, it gets protruded, or because of the previous surgery or surgeon's wrong techniques, it gets protruded. So these are the two major things we come across. And the challenges we face is like bone is structurally impaired to give stable fixation, especially in inflammatory arthritis or in angst, like maybe very difficult to get out of this head. And severe protrusion, you have severe issues of in exposure and dislocation. Most often you will have to do a cut, in situ cut, and extract the neck like you do in a fracture neck of femur. And if you fail to lateralize, and if you happen to keep the cup in the protrusive stage, it can have a risk of impingement and subluxation or dislocation in future. And definitely that will lead on to the abductor inefficiency also. And the biological factors, especially in inflammatory arthritis and associated osteoporosis, if there is an uncemented cup, there can be problems of bone ingrowth, especially in peripheral fit cups you use. And in cemented, if you're using cemented cups, again, like medial wall may be thin and the lack of stable interface, and the micro interlocking may not happen, and the thermal necrosis because of the cement can worsen the things further. So what we need to correct in protusia is, one, strengthen the medial wall and acetabular integrity, lateralize to restore the hip biomechanics, and ensure component coverage, as it is already told, that if you get at least 70% of coverage and 30% of uncoverage is acceptable in uncemented cups. But if that is not getting, you will have to go for a cemented cup. And secure rigid fixation, like especially in a peripheral fitting cup, you cannot rely on the screws. If you feel the cup is loose, you cannot rely on the screws to get a rigid fixation. The screws doesn't give a rigid fixation. And if there is reconstruction, already like told in the previous lecture, if there is reconstruction, you can either bond graft it or use acetabular augments. And preoperative planning is very important, as in DDH here also. Like you have to identify the underlying disorder, because like most often, like we get untreated inflammatory arthritis or inflammatory arthritis treated by traditional methods and finally come up with protusia and bone weakness. So unless you identify and treat the primary cause also, that can fail. And of course, the aim is to restore the hip mechanics and correct the limb lengthening and assess the bone stock and decide whether you need to do a bone grafting, or if there is bony defects, you have to go for augments. All these things should be planned. Maybe a CT scan will be very helpful in assessing the bone defects and all, and deciding the size of the cup. There's no point in being heroic and go for ream and go for higher cups and try for 36 cups and all. Like it may further damage the bone. And two things will help in this. One is the teardrop assessment of teardrop to assess the placement of a cup, and the Runaway triangle, where the base point is like 0.5 millimeter lateral to the teardrop, and an isosceles triangle you mark with the limb of the triangle as 20% of the pelvic height. That will give you a rough idea of like what size of cup you are going to use it. And coming to surgery, like exposure, it doesn't matter whether you go posterior or anterior, whichever way like you are trained and you are confident, that is the way you should go. And if it is very difficult to like dislocate, don't try to give more forces and try to dislocate, because you may end up in a fracture, either in a fracture neck of femur or an acetabular fracture. So try to do an in situ neck cut. And if it is very tight, soft tissues are very tight, then probably you have to go for a trochanteric osteotomy. But most of the cases, like you can escape without a trochanteric osteotomy. And especially in severe protusia, you can see the sciatic nerve may be very close than you expect, especially when you go posteriorly. So be careful about that. And do not ream medially. That is the most important thing when you manage a protusia stabile. And try for a peripheral. If you're going for an uncemented cup, try for a peripheral fit. Do not ream. And there are different ways of reconstructing the defect. Like either you can completely rely on the cement and use a cemented cup, or you can do a bone grafting on the medial side, and over that you can cement and do it. Or you can do a bone grafting and a cementless cup. Or in case of defects, you have to go for a ring or cage or a cup cage construct. So this is an example of a cement augmentation. It's a most easy way out, but be careful, because like your version, your hip center, everything is in your hand. You can completely go wrong if you're not. Probably it's a good idea to use ZM while placing this cup in such cases. And you have to be aware of thermal necrosis that can further cause on the medial side. And this Ranawat paper shows that 16 out of 17 hips got loosened when the hip center was more than 10 millimeter from the anatomic side, and no loosening when hip center was less than 5 millimeter, especially in when you use a cemented cup. So when there is a defect, next option is to use a ring or cage. It's a safe bet. It's more useful in revisions. And positioning may be difficult, because it's like cutting the feet according to the size of the shoe, because you have to select the rings and you have to manage your acetabular accordingly. It may not be getting seated properly. And it's better you bone graft the medial side, especially because like in rings and cages, the life is not as good as a normal cage. So there's a chance of revision comes. So in that case, if you have done a bone grafting on the medial side, like your life will be easy in the second surgery. And remember, these cups do not seat flush. So don't impact too much and try to get a flush seat. An example of an 80-year-old male with a bipolar done 3 years back came with protrusio and a huge HO and loosening on the side. And I think like in such cases, especially 80-year-old, the best option is best bet is to directly go for the cup cage construct. You can see that cup is not seating, it was grafted medially, and 1 year down the line that it was getting well incorporated. So bone grafting is a gold standard in protusia stabile. It helps in lateralization and arrests the progression of medial migration. Again, Ranawat suggests if it's less than 5 millimeter, no bone grafting is needed, but it's more than 5 millimeter, bone grafting is a normal cup. In severe protrusion or deficient medial wall, augmentation device, that's the key. And if you look at the literature, like in protusia stabile with bone grafting, actually impacted mosseized graft with cementless components like fare better than similar components. And we have an Indian paper where a mosseless bone grafting plus a cementless cup has given very good results from Arun Mullaji. This is a 76-year-old gentleman, history of neck of femur earlier, like now pain instability and X-ray shows like medial and superior migration. This is, if you look at the surgeon has gone wrong by all principles. There's no lateralization, and it is like the inclination is wrong. You try to like get a stability with the screws, and the limb length discrepancy is still maintained. So definitely patient is not going to be happy, and definitely these kind of fixations are going to fail. Another case of where the surgeon over-reamed, and the first post-operative day when he walked, it got fractured. And when we did a CT scan, like the posterior wall was fractured, again converted to a cage construct. And this is again another case of Angst-Pont. THR was done that, but it worked around more than 12 years, and then came with the cement protruding medially and the stem going up. So it was revised again with a cage construct, and a primary hip was done on the other side. And it's 10 years down the line now, still happy. Sometimes we come across with such situations like patient go for a lot of other treatments and finally end up with these kind of scenarios. And actually, when you assess, there's only protrusion, there's no acetabulum. So then in such cases, probably you'll have to think out of the box. One option is to do a 3D printing and go for a custom-made processes. That is one option. It's going to be costly and time-consuming. And again, considering the age, I decided to go for a process like this. So which is usually used in tumor processes, but in this case, it worked well. So basically, in protrusio stabile, in a proper pre-op assessment and meticulous planning and proper armamentarium, these are the three things you need. If you don't have these things, don't venture into those things because you will land up in trouble. Thank you.
Thank you, Dr. Vijay. May I call the last speaker of this session, Dr. Subhash, for intraoperative fractures of femur in THR.
Is Dr. Subhash there? Dr. Subhash Jangid? Meanwhile, since he's coming, do you have any questions on the floors? If I may ask, is Dr. Karthik Patel there? Or has he left? He's left. Dr. Vijay is there? Dr. Vijay, yeah. So I just wanted in your protrusio cases, when you're doing a bone grafting medially, do you keep your bone chunks as 8 to 10 millimeters or still you keep it lesser?
You mean the size of the graft or?
Size of the graft, size of the graft.
What I usually do is I use a reverse reaming of the head, get the cancellous graft and pack it and do a peripheral fitting cup.
Okay, because in cases of mild protrusion, you can do what you're doing. So you can use the reamings and then use it if it is less than 5 millimeters. But in cases of moderate to severe, when you use the bone graft, it is very important to use thick chunks, which are 8 to 10 millimeters minimum. So 8 to 10 millimeters is recommended when you're doing it in severe protrusion, like you have a completely grade 3 or grade 2. You have to pack it up with that because they would act more like a structural. The rest of the reamings, they just get absorbed. So for moderate to severe, you should use 8 to 10 millimeters. That is the recommendation, which is there for. Rest for mild, you can use the reverse reamings. That's not a problem. And in cases of protrusio also, if in case, you have, when you're reaming, do you do it anything different when sort of a constrictive protrusio is there, or sometimes, you have a, you have at the opening, you have something which is very small and inside it's more like a opened space where you have a constriction at the opening of the acetabulum, vis-a-vis where your acetabulum is quite big also to open. Do you do any different reamings for different situations like you, or is it your standard reamings that you do?
It's standard, basically do a peripheral reaming. As you said, if you feel that periphery is tight and the inside is big, your uncemented cup may fail. In that case, straight away go for a cemented cup. That's what I do.
So when you have these kind of protrusions in constrictions, what I have seen is that you try, because initially when you're trying to ream, it is too constricted. So let's say if you're putting 40 or a 42, you ream and suddenly you go down inside and then it opens up. So it's like a 52 inside, whereas at the opening it is 42. So generally what I do is that I keep it at what is there at the rim and I don't bother about what is happening inside, because there you have to pack it up with the bone graft. It's only the peripheral, because if you try to match it up, you keep reaming and then I end up with a jumbo cup, like a 60 rather than that. So when you have a constriction at the opening, it's better to just go slow and go only with the peripheral rim, like you said.
Concentrate more on periphery. Basically.
Correct. That's what it is.
The last question from the gentleman.
Hello.
Please.
Yeah, this is Dr. Jay Sharma. Sir, a question for Dr. Vijay Mohan, sir. That acetabulum defect, where there was a large bone loss, which implant was used? I've not seen it earlier. Behind you on the right.
Which one, the Angspon case?
No, that lady whom you showed walking with completely.
That's a saddle process.
Saddle prosthesis.
Yeah.
Okay, sir. Thank you so much.
There's a notice that the next live surgery is actually the patient is in OT. So let's close the session right now. And I think we should move on to the next session, which is a live knee replacement surgery. The patient is already in the OT. Thank you.
Thank you. Thank you very much. Thank you, moderators, Dr. Amandeep Bakshi and Dr. Vaibhav Kasodekar. Let's move on to this next live surgery that's to be done from Paras Hospital in Gurugram. Operating surgeon is Dr. Vivek Logani. And moderation, may I request Dr. Kiran Choka and Dr. Dimple Parikh to moderate the surgery. This is supposed to be a navigated total knee replacement.
इसमें हेडफोन ही लगेगा.
Good morning, everyone.
Check. Hello. हाँ सर, मैं मोबाइल पर हूँ. हाँ जी, वो फ्रंट कैमरा ये आगे से डिस्प्ले. ओके. नहीं अभी सर ये दिखाना है डिस्प्ले भी. हाँ, अभी डिस्प्ले जब एक्टिवेट करेंगे ना ट्रैकर्स वगैरह, उस समय दिखाना है. फिर उसके बाद जब बीच बीच में मैं इंस्ट्रक्शन दूंगा तब. हाँ हाँ सर, मेरा कैमरा रेडी है. ओके सर, आप बता देना सर. आप जैसे लेंगे बता देना. मैं एक्टिवेट नहीं करना. वो जब सर्जन बोलेंगे ना वहीं पे मशीन के पास ही वो कैमरा सर रेडी है. ओके सर, वी आर लाइव इन 5 seconds. 5 4
3, 2, 1. We are live now, sir.
Good morning. I can't hear anyone.
You are live. But current will not speak something. So you will speak something.
No, but I have to communicate with them, no?
You will see your camera.
The session started, sir?
You can say hello to him. Sir.
Hello? 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 Is there anyone out there?
Is there no way to communicate? It's very strange. All right. Can you focus on the X-ray, please? Yeah. So here we have a patient with osteoarthritis of the both knees. It's a few degrees of varus, 10 to 15 degrees of varus, and about 10 to 20 degrees of flexion deformity. Yeah, can you focus here? Yeah. So I'm Vivek Logani. That's Dr. Rahul, Dr. Mahesh, and Dr. Manisha. Manisha, look at the screen. All of you are going to guide me for the surgery. Thank you so much. So we're just going to start in a few seconds. Okay. Okay. So we are going to use a mid-vastus approach. Can you focus here?
That's the usual routine approach you approach for this TK.
Hi Vivek, can you listen us?
We are splitting the vastus medialis obliquus here.
Vivek, can you hear us?
We are releasing the medial sleeve a little bit so that we can just access the posteromedial corner. No extensive release at this point of time.
Hi Vivek.
We don't need to rotate the tibia because it may put stress on the distal tibia. So as a routine, we don't rotate the tibia for reaching the posteromedial corner. Just removing some synovial attachments.
Can you hear us?
Here.
Can you hear us, sir?
We are
Sir, can you hear us?
making a space between infrapatellar fat pad and the upper tibia.
Are you able to hear us, sir?
Are you able
Are you able to hear
sir?
us from the
We'll remove
auditorium?
a bit of synovium here, just enough to have clear vision of the distal anterior femoral cortex for accurate sizing.
Sir, can you hear us? Yes, sir. Hello. तो उसको बोलो सेटिंग्स में स्पीकर चेंज कर. हेलो. फोन क्यों कट कर रहा है वो? बोलो उसको उसके स्पीकर में चेक करने के लिए.
Can you focus here? We are cutting the lateral patellofemoral ligament and a few synovial bands here because they ease out the lateral retinaculum. It should not be confused with lateral retinacular release.
Hello. Can you hear us?
This
Hello?
we do in all the
Hello?
cases.
Hello?
Because this makes the patellofemoral compartment
you
relatively
hear us,
more
sir?
comfortable
Hello?
and also improves the flexion to some degree.
Can you hear us, sir?
This is known as internal patellar release, removing just a bit of lateral retinaculum from the lateral facet. Again, this makes the patella quite comfortable. Some of the synovium from the infrapatellar fat is going to be removed. This is the suprapatellar fat pad, which must be removed in all the cases because otherwise we leave a nidus here for rubbing against the femur and it might turn into a nodule later. So it's always a good idea to remove the suprapatellar
Can you hear us?
fat pad here and burn the residues.
Can you hear us?
The patella looks decent. We'll just smoothen the margins of the patella.
YouTube पे भी आ रहा हूँ. Hello? Can you hear us? अरे उसको बोलना भाई आ रहा है तो अपना स्पीकर चेक करेगा. इतना देर लगता है क्या? मोबाइल पे आ रहा है तो फिर उसका आना चाहिए ना. लाइव के टाइम पे क्या कर रहे हैं? क्या है मेरे को मेरा आवाज सुनाई दे रहा है यूट्यूब पे. मेरे को यूट्यूब पे आ रहा है मतलब बाहर जा रहा है. हाँ तो उसको बोलो करने को. डिस्कनेक्ट करके करने तो डिस्कनेक्ट करके करो. कितना टाइम लगता है?
Now we'll
अरे तेरे पास
remove the tags and the attachments.
Dr. Vivek, are you able to hear us?
All right.
Unfortunately, we are not able to communicate with him.
Now, before we proceed for
In
further
case if
things,
you have
we
any
would
question, please ask.
remove the medial and the
We'll
lateral
try to answer
osteophytes
you.
so that we know how much is the correct status of joint tightness or laxity or whatever.
Hi, Vivek, can you hear us?
We must always focus on the total amount of space that we wish to create for our implants. The total space is contributed by
Sir, can you hear us? Please reply us.
the patient's inherent level of soft tissue laxity.
Hello.
The space accorded to us by the removal of osteophytes and the space accorded to us by doing legitimate soft
Hello.
tissue release
Sir,
in
please
case
reply.
there is a pathological tightness
can
in
hear
any
us.
kind of soft tissue. And finally, the space achieved by the bone cuts.
Hello.
We must not rely only on the bone cuts
Excuse me, sir.
for
So Dr. Karthik here.
the space that we require for putting the implant. So if we follow this sequence
Patellofemoral ligament
and maybe
that sir did, do you
give
recommend
last
doing
priority to bone cuts
personally? I don't do it because it helps
for
in
achieving that space, and before that we
So do you recommend doing
use
that
all the armamentarium available to us
each and
by
every time?
removing the osteophytes, by doing
It's basically a denervation of
legitimate
patella.
soft tissue releases
Because if you are not,
wherever required,
before that
we would be
retinaculum
able to minimize bone
gives
cuts.
you better
In
exposure.
case
So if you
for
are
some
taking a
reason
small incision,
in a sequence there
then
it is
is
not
helpful to
possible
have a better
to
retraction of the patella.
to
Otherwise,
remove an osteophyte before we make a bone cut, then we must
It's
be
better
able
to do
to
it. Why I do
anticipate
is basically to increase
that
subluxation.
okay, these
So
are
let's
the
the
amount of
patella.
osteophytes
Better to do
available here.
Use lots of
And
space.
once I remove those osteophytes, this much space will be
No,
available.
what happens is so
Let's
many
say, for
times we end up
example,
when there's a tight joint, if you don't release that
I
thing, then
extend
when
the
you
knee
cannot
here.
subluxate, there are chances that there
And I
might be
say
a
it
patellar
is-
avulsion
Can you
or
show from here?
such kind of complications.
It is neutral.
Do you do subvastus?
There is no flexion deformity
do,
here. It is
middle
neutral after removal of the
parapatellar.
osteophytes. And I know that once I am putting the prosthesis, I'll be removing some posterior condyle, some overhanging posterior condyle from the posterior margin, which will accord me some maybe a millimeter or 1.5 of the extension space. So I will plan my distal femoral resection accordingly. Can you show from here? You have to come here, this side, this side, you have to come. Now we look at the femur from the lateral side. Yeah, and we see this anterior distal femoral cortex. This is the final guideline to us regarding the sagittal plane flexion of the femoral processes. When we use navigation, we are not using sagittal plane mechanical axis for assessing the femoral flexion or extension. Ultimately, the anterior femur must be flush with the anterior distal femoral cortex, which is in a few degrees flexion to the sagittal plane mechanical axis. So what we do here is we make a provisional anterior femoral cut, which will be fine-tuned later. It is just a provisional. And this gives us a reference for putting our jig and changing our femoral flexion and extension intraoperatively from case to case. So now I will put this navigation attachment jig on the femur. Can you show the navigation machine? Can you start? This is an active navigation system where we have active infrared emitters. Okay, so we have already activated all the trackers. Now we are going to find the hip center by circumducting the hip in varying degrees of radius. So it has found the hip center. I will tell the knee center to the machine. For the sake of reproducibility, we use the highest point of the intercondylar notch after removal of the osteophytes to mark the knee center.
Yes, please.
Femoral AP axis. That means I'm telling the system that this is the anterior side of the femur. So I will mark the medial condyle for assessing the depth of the cuts. It is done. Now I will mark the lateral condyle for assessing the depth of the lateral cut, from where it will take a reference. Okay, now this is the universal cutter that we have here. I can fine tune varus valgus as well as flexion from one single cutter here. Now, I want to cut 8 millimeters here because I know 1 millimeter or so I will gain from the removal of the posterior overhanging posterior condyle. Yes. I want to put the coronal plane axis 0. That means it's perpendicular to the coronal plane mechanical axis. Can you come here again now from this side? I'm not sure whether the cameraman is focusing end on here, but I can see here that once I make it a degree or 2 degrees flexion, my jig becomes parallel to this anterior femoral distal resection. So this is my final reference. Adjusting the depth of the cut here as 8 millimeters. So we are good to go. We take a snapshot here and we fix the jig in this position. So the femoral navigation portion is over. We take the distal femoral resection first because this is the least commitment level in a knee. We are committing only to some portion of the extension space when we take the distal femoral cut first. If we take the tibial cut first, we directly commit both to the flexion as well as the extension spaces. So The other reason for taking distal femur first is that once we are delivering the tibia, especially in difficult knees, it's easy to work around the tibia because we get some more space here. Yes, I can measure it. It's 8 millimeters here. So now, before we go for other things, we don't want to cut the posterior femur here because we don't want to commit to the flexion space. Because once we are done with the tibia, we'll get a reference for putting our 4-in-1 femoral cutter. In case the posterior condylar anatomy is distorted, we would put the 4-in-1 cutter parallel to the cut surface of the tibia. That is one reason. The other thing is, once we are cutting the tibia, we are committing to both the flexion and extension spaces. And later on, if we find that the flexion space is mismatching with the extension space that we wish to create, we still have the option of upsizing or downsizing the femur so as to match the extension space that we have created. So I'm removing the the tibial osteophytes here. So here we make a preliminary assessment of the extension space without cutting the tibia. Can you focus here? Can you give me a spacer? Yes, we just make a gross assessment here by putting the spacer flush with the distal femur. So we know, I mean, we can mark it for showing to someone. We know here that from the medial side, we hardly need a millimeter of 2 of the cut to get this spacer inside. The genicular vessel comes precisely here. If it comes, we burn it. All right.
यहाँ से जो बोलते हैं वो
हेलो चेक 1 2 3 हेलो
सुनाई दे रहा है ना, प्रशांत भाई बोल रहे हैं।
हेलो हेलो
हाँ, तो वो चीज लैपटॉप में आएगी तब सर को सुनाई देगा ना आपके
हाँ
यहाँ
भाई
पे।
हेलो
लैपटॉप से कनेक्ट करो जल्दी। एक बार मोबाइल आप बंद कर दोगे तो भी चलेगा, लेकिन लैपटॉप आना चाहिए।
अभी आ रहा है लैपटॉप पे
मार्किंग द
डिस्प्ले दो
medial condyle. I'm specifically marking the posterior portion of the tibial condyle from where I want to assess how much am I going to cut. And now the lateral condyle. We should take care that we mark the highest portions of the lateral condyle for taking reference, the medial malleolus and the lateral malleolus here. With these two references, the system would calculate the ankle center. Point.
Hello.
So here we have this
Hello.
provisional jig attached here.
Hello.
But first of all, make it neutral.
Hello.
In the coronal plane. Okay.
Sir, can you hear us?
Now.
Hello. 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 Sir, can you hear us? Hello. Hello. Hello.
हेलो
Hello.
फोन ही कट कर दिया उसने
Hello. Can you hear us? Hello. 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 Can you hear us? Hello. Hello.
भाई यहाँ से आवाज आ रहा है कि नहीं आ रहा है
Hello.
Yes, can you focus here?
Hello.
We use a comma guide to see how much are we cutting.
Sir,
from the
can you
knee.
hear us?
Just about 2 millimeters.
Can you hear
from
us?
the posterior most portion of the tibia, which looks good to me. And
Hello.
the depth of the cut is 9 millimeters.
वो ठीक है, तू ये तो वीडियो देखा था। यार people are walking out यार, तुम लोग वो नहीं देख रहे हो। मुझे मेरे को आवाज सुनाई दिया।
So the tibial navigation
हेलो
job is over now. I'll recheck how much tibia we are cutting.
नहीं सुनाई दे रही तो आपको करना पड़ेगा ना सेटिंग्स
Hello. Hello. Hello.
फोन डिस्कनेक्ट करना है क्या मुझे हाँ तो अभी सर को बोलो कम्युनिकेट करने के लिए
Hello. Sir, can you hear us?
On.
Sir, can you hear us?
Yes, yes.
Yes, please.
Yeah, sir. Full view कर दो।
Hello. Vivek, can you hear us?
Yes, yes. Only
I'm
now
glad.
I can hear. Till now it was only a one-way communication.
Yeah, that was unfortunately.
I was
it was-
told that I just have to unilaterally.
So you have to give a commentary rather than.
Okay, who is it? Is it Dimple?
Yeah, I'm Dimple here. How are you?
Okay, good morning. Good morning.
Very good morning.
Were you able to see and hear what I was talking?
Yeah.
about?
We are able to see everything, and we really appreciate that.
So they told that I have to speak to a ghost and start the surgery. So we have taken the tibial cut based on the parameters that we just told. So we use a limited navigation system which guides only the alignment cuts.
Yes, distal and
because
proximal.
this is practically very useful for us to calculate the things which we cannot see with naked eyes or measure with our instruments. For the rest of the parameters like joint space and the rotation and the balancing, since all of those parameters are directly in front of us in the knee and we can actually measure them directly, navigation does not calculate anything new for us for the local parameters. So we skip those portions in the software and save good amount of time and still lose nothing. So we must utilize technology to our best advantage where it actually adds value to our assessment. We should not let it be just a visual representation of or a graphic representation of what we can already see in the knee. So we cannot see the center of the hip and the center of the ankle, and that's where we are taking the help of technology. Okay, can you focus here? So as I said, we have taken the distal femoral cut and the upper tibial cut, and we have a preliminary extension space here. Can you give me a spacer? Pull करके रखो. Yes, we know this spacer, which is meant to accommodate about a 9 millimeters poly, is barely going in. Okay, we still expect some more extension space to be accorded to us once we remove the posterior overhanging portion of the posterior condyle. And so now we know that this much extension space is good for us.
The patient had some flexion deformity before you start the surgery.
Sorry?
Right? Patient had a flexion deformity before you start the surgery.
Yeah, it was about 10-20 degrees visible from outside.
Yes.
But once we removed all the osteophytes and everything, it became neutral. So that is why I said, before we embark upon the bone cuts, we must remove all the osteophytes and then finally assess what we are left with. So here we have the preliminary flexion space already available to us. Once, can you focus here?
Yeah, we are
Yes.
able to see it. And so
Yeah,
we are
you're
going
able
to check
see.
with the.
So based on this, well, if I want, I can put a gauge there to actually measure it, but it looks like maybe 2-3 millimeters on both the sides. So based on this, now I can still upsize or downsize the femoral the femur to match the extension space that I created. That is the reason we prepare the femur 4-in-1 cutter in the last. So let me measure the size. Based on that, I will decide what to do.
So the very important thing one should remember is male patient with flexion deformity on table do not leave any flexion deformity because they usually tend to be very tight. If female is there and they have some flexion deformity, it is okay because they tend to loosen out later on.
So here we have a size between E and F when I measure.
Right.
I know by practice that F will be bigger mediolaterally for this patient. So I am downsizing it a little bit and I'm putting the rotation here 3 degrees on the medial side and 6 degrees here so that we don't have a significant
extra rotation
enlargement of the flexion space here. E. So can you give me the spacer here again?
So if you are using 6 and 3, the rotation will be less. The external rotation.
I'm using 3 degrees on the medial and 6 on the lateral. That means it will become 4.5 degrees.
Okay. Sorry,
Okay.
literally you are putting 6, right? So it will have a more.
Okay. Yeah. So I can put my provisional spacer here and see that it is going to fit there. So I'm happy this way. In case I need to upsize the femur for some reason, then to avoid tightening of the medial flexion space, I would put 6 degrees on the medial side and 3 on the lateral side.
Instead of doing that thing, you didn't consider pie crusting the MCL, sir?
Sorry?
Pie crusting the MCL so that you can increase the medial
No,
space,
it's not
avoiding
required
the
in this
rotation.
case. And whenever the femoral anatomy is distorted, like when I cannot rely upon the posterior condylar anatomy, we would put our 4-in-1 cutter parallel to the tibial surface and use an anterior stylus here to see that it is not notching, and that is the final guide. So ultimately, we should be flexible with the amount of rotation that we are giving. So
What are the criteria you decide about rotating the femoral component?
Sorry?
Increasing the rotation. Here you have rotated the femoral component by 1.5 degrees. Yeah, increase the rotation. What is the criteria which you look?
Yeah, if the posterior femoral anatomy is normal, like no condyle is underdeveloped, then I would use the posterior condylar reference jig to mark the rotation. And if it is normal, then I would use this tibial component axis as the guide to see how much rotation do I give to make this 4-in-1 cutter parallel to this guide after stretching all the ligaments. So can you show me the anterior stylus here? So when we use the freehand technique for deciding the rotation, we put an anterior stylus here and we fix it with the anterior portion of the distal femoral cortex to make sure that we don't notch. And then we are free to rotate it whichever way till it becomes parallel. And we can rotate it, we can move it medial and lateral also. So that's a very, very nice way of handling the femoral rotation to make sure that we are do not have an eccentric flexion space here. So we finish the femur here. Can you show here? यहाँ पे दिखाओ. Yes, this is another telltale sign that the rotation is fine.
Yeah,
The
looks
grand piano
perfect.
sign, as we call it. Yeah. So now we're done with the femoral preparation. So now we are going to look behind what we are left with. Some portion of the premeniscal tissues here, which are hard, should be removed because they might impinge in deep flexion. All right. And I'm just going to look how much portion of the posterior condyle would be overhanging beyond the processes. We make a curve in the femoral cautery here. Can you focus here? We make it curved a little bit so that it stays just on the bone, and we just erase whatever capsule is just sticking behind
Posterior
the
capsule.
condyle, so that removal of this portion becomes a little easy.
Audience, any doubts to the surgeon?
Even you can release the posterior capsule with that cowed.
I'm not releasing the posterior
Yeah.
capsule. I'm only removing the overhanging portion of the osteophyte. I do not think that the release of posterior capsule is required in this particular case. It is not pathologically tight here. So as
I know,
I
I'm
said
just-
earlier, soft tissue releases should be done only when we are dealing with the pathological soft tissue tightness.
I agree with you. I'm just telling the
Yeah,
audience
yeah,
that
yeah.
you can release a posterior
Yeah, yeah.
capsule.
Okay, so we are now done with the posterior clearance. I'll check again with this small curved nibbler. If anything else is left, it looks clear to me. Now, can you focus here? Yes, this thing. We always remove this portion of the distal lateral femoral condyle. We nibble it, particularly because
Sir, one
although very
query.
rare, there is something called popliteus snapping over
What
this.
is the rationale behind keeping external rotation medial 3 and lateral 6?
Vivek, there is a question. Vivek.
I told earlier that the size was the size that I measured was more than E. All right.
So
So I wanted to put E because F would not fit mediolaterally, it would overhang. So if I put medial 3 and lateral 6, that means just a minute. When I put medial 3 and lateral 6, that means when I'm sizing the femur, the flexion space on the medial side would increase. To minimize the increase in flexion space, I'm putting 3 here. And now on the lateral side, when I'm downsizing, the flexion space would increase. To minimize the increase in the flexion space, I am putting 6 degrees here so that my 4-in-1 jig moves a little more closer to the tibial plateau. So I am trying to offset the effect of downsizing the femur on the flexion space by using this maneuver. On the contrary, if I upsize the femur for some reason, if I have to, then I would put 6 on the medial side so that I cut a little more of the posterior condyle from the femur here, and my flexion does not become unduly tight because of upsizing. And when I put 3 on the lateral side in case of upsizing, I am again offsetting the effect of upsizing the femur and not compressing the flexion space too much. I hope that makes it clear.
Yeah,
so I'm going to use the trial here. The net rotation remains the same, whether I put 3 on the medial side and 6 on the lateral side, or 6 on the medial side and 3 on the lateral side. Net rotation remains 4.5 degrees only. And this is only a broad guideline. If we are in doubt, we should use the either the interepicondylar axis or the gap balancing technique, as I just told earlier. I can see my flexion is absolutely comfortable, neither loose nor tight. And my extension is also comfortable. Can you focus here? Neither loose nor tight. So we have finally achieved what we wanted to. And in all degrees of flexion, the stability is quite good and comfortable. When I deep flex, there is no lift off here anywhere. And can you focus here? Can you see the tracking here? The tracking here is quite good without the application of any thumb or anything. Do we have time to move ahead for the cementing? Because there are interesting things to see there.
Nice demonstration.
Sorry?
I think, yeah, we are going to, because we are going over time. So
No problem, no problem.
So I think we'll cut off from the, because we have got a couple of lectures which are pending.
Sure. Please go ahead. And
Vivek, I mean,
please.
do we have any question for Dr. Vivek? Anybody? Yeah, there is one question for you.
Sir, is there any chance by increasing the external rotation, we may create some notching, particularly laterally, by increasing the rotation from 3 to 6 or 4.5 degrees?
So Vivek, Dr. Rajesh from Ahmedabad is asking that you are increasing the external rotation of the femoral component. So by which are you going to, or by any chance, are you going to notch the femur?
No. I have not increased it so much that I notch the femur. It's only 4.5 degrees. And ultimate bottom line is that we should have a symmetrical flexion gap there.
Right.
No matter what rotation you put. So in case we are using the freehand technique of putting that 4-in-1 jig, as I told earlier. Can you show me the stylus here? Yeah. When we use the freehand technique, can you focus here? We use this anterior stylus to sit on the anterior lateral femoral cortex. Just show here, like this. We are using it as a reference to make sure that we are not notching. And now we can rotate it whichever way we want till it is parallel to the tibial cut. I ask Dr. Mahesh to put a gentle traction to make the ligaments equally taut, and we can see in an end-on view whether or not this is parallel. If you still have a doubt, you can use a spacer to make sure it. If you still have a doubt, we also have a calibrated balancer. Just show. We also have a calibrated balancer here to measure the flexion and the extension spaces. So ultimate bottom line is that we must have a symmetrical flexion gap no matter what rotation. To prevent notching, as the gentleman rightly pointed out, we use a stylus here. I
Great.
hope that makes it clear.
Yeah.
Yes.
So it's a hardly 1 or 2 degree of external rotation, 1.5 degree. So that's not going to be an issue. Or by any chance, if happens, it's a half notching. So it's okay. Should not be any problem. So medially you are not notching. Laterally you are just notching by a millimeter. So that is acceptable. The important thing is that we should have a very equal flexion extension gap so that the patient feels like a normal joint. So if you are downsizing the femur, there is a possibility it increases the flexion gap, and then while getting up from the sofa or getting on the staircase, they feel instability. So this is very important thing. Right, we will, Vivek, we are going to log off and.
Okay, thank you. Wish you all the best for the rest of the day.
Thank you so
Thank
much.
you. Thank you very much.
Thanks for the
All right,
presentation.
bye.
Thank you, sir. So we have got one lecture, which was from last session, which is left out. So can I request Dr. Subhas to come on the stage for his lecture on intraoperative fracture of femur in total hip replacement surgery? There are two different systems. This is navigation system help us to achieve the distal and proximal cut, and then further you go on. But he has not shown, even after that, you put the trial implant and you can check the ligament balance and how much flexion you are getting. So that is also additionally, we are able to get it. So it's the robotic system is extension of navigation system where the cuts are being done by the robotic arm. So this is one of the fantastic tool to go ahead with the more advanced technology.
Good afternoon, friends. Sorry for the delay because of the flights and other issues happening nowadays. Just to keep you busy for some interesting topic before the lunch. So intraoperative prosthetic fracture, we call it. It's a femoral fractures, and it's a very common thing to occur and becoming more and more common nowadays because of the more and more use of the non-cemented prosthesis worldwide. And if you see the Swedish registry, the trend is changing more towards the uncemented. And I'm pretty sure that this data which I'm showing from the registry is absolutely reverse in India. Like we are using more and more cemented in India and USA rather than in the UK. They may still be having the same ratio. The problem is that the periprosthetic fracture or the femoral fracture is one of the major cause of the revision. If you see, it's there in the top rank of the 5 major causes of the revisions. And out of these major causes, the femoral fracture is the number 2 cause of the revisions after the aseptic loosening of the prosthesis. So we are dealing with a very, very major issue here, and we should try to prevent this as much as possible. The problem is that it's usually not recognized because either it's concealed by the prosthesis on the other side of the surgeon's vision. And that's why it's very, very underreported, the intra fractures. Post fractures we all see, we can see on the X-ray, we can get a CT scan, but intra fractures, that's why they're underreported. And the major issue that they need revision because ultimately most of the primary stems are having the hold in the proximal metaphysis. And if there's a fracture, the process is going to get loose and you need a revision. And you see the incidence is much, much higher in the uncemented hips and in the revision surgeries. And if you see the broader epidemiology, the major review study, it's 14 times higher in the uncemented hips and majority are at the calcar femoral. So your implant hold is going to lose if you get a fracture of the femur. Now, what are the major risk factors? You should be very, very careful when you're doing it. If you're using a minimal invasive technique, that means you're not going to visualize the femur in a proper way and you tend to miss the intra fractures. If you're doing a revision surgery, when using a long uncemented stem or a short stem with an impaction bone grafting, if you are too harsh on the bone, you may lead to a fracture. Female of a increasing age that is more than 65 years of age at a high risk of fractures. Metabolic bone disease when the bone itself is diseased, or technical error when you are doing the surgery. That means you are putting the force in wrong direction. That can also lead to a fracture. Now, if you see that some specific type of implants, the single wedge or double wedge design, which are actually fill and fit design, they are more prone to have these kind of fractures rather than a fully coated or anatomical stents. So you should be very, very cautious in using them in an elderly female. Now, one interesting study is that regarding the broach handle, most of the original broach handles are straight. So you are hitting in the direction of the broach. Now, nowadays, a lot of minimal invasive techniques have come up and the broach handles are curved. So very interesting study that if you use a force in a curved handle, the actual force to move the femur or the broach 1 millimeter is 200 times higher. Now imagine the impact on the bone, the hoop stress on the bone, and that force goes towards the lateral cortex. And if you try to go slightly in varus, your calcar femur is going to fracture. So that's very, very interesting thing to understand when we are moving towards the minimal invasive technique. Now we need to prevent it. That's the best thing to happen. So when you're using a broach, I'm not sure you're able to hear the sound of this video. So when you're using a broach, there's a change in the sound and you need to stop there before pushing it more hard and go back and forth so that you don't injure the calcar. Now, when you're putting the implant, when you're putting the femoral implant in, is the other way around. When you're putting the acetabulum, you hammer very hard. When you're putting the femoral component, you should be hammering very gently. You can have multiple blows, but not very harsh. Reason being because whatever implant you're putting, you already made a space for that with a broach. If you put too harsh, it will break the femur, or your femoral component is not going the proper direction, or some soft tissue or a bony fragment is there between the component and the femur. That's the reason you get a fracture. So you go very gentle when you're hitting the actual prosthesis. Now, diagnosis, you need to have very, very highly suspicious of if there is any loss of resistance when you're putting the component, because that leads to loss of fixation and ultimately a revision in the post-op period. Now, Vancouver also gave a classification for the intra fractures. So type A and type D are actually perforations. Usually, if you have an old prosthesis there or old DHS or DCS or some fibular graft has been there, you cannot go in that direction, and sometimes you try to drift your drill or reamer in the lateral cortex and cause a perforation. So that's A and D. And D is usually in the revision scenario when you remove the proximal part of the prosthesis, distal part, there is some bone formation and your drill bit drifts laterally or medially, and that causes a perforation. Now we'll discuss the A and D are primarily intra when you recognize and then you tend to change them. We'll see some examples of the other fractures. Now, as for the treatment is concerned, there is no ideal treatment. Depending on the, like for a fracture, there's no ideal treatment. For each and every fracture, you have to plan your surgery, how to fix them, intra-op, you need to put a compression screw or not. So based on that, there's no ideal treatment, but you need to ensure that your hip arthroplasty, which was the primary treatment for that patient, is stable and your fracture is also stabilized properly so that the implant has a proper life of the for that particular patient. Now here's an example of type B fracture, which is an undisplaced GT fracture, which happened during the surgery, recognized after the surgery in the post-op X-ray. Now it looks very innocuous looking fracture, and we left it as such without any problem for a few months. After a few months, it got displaced. So how much of force attached to this bone is very visible on this X-ray, but patient obviously refused the surgery, and now 7 years down the line, she's still walking with the limp. There's some fibrous tissue has been there between the bone and the fragment, so the muscle is working, but there is a limp. So the results are compromised. So always keep a watch. If there's a fracture, try to fix with the proper method so that the patient has a good result. Type C fracture are the same GT or LT fracture with the displacement. Now, a lot of force is there, so they tend to displace and need to fix them intra-op. Case is like this, where there's a fibular graft inside the neck of the femur. You tend to drift away. Your femoral component tend to go into varus. It causes a fracture intra-op. But somehow we missed it during the surgery. We found in the post-op and we went back and fixed the fracture with a cerclage wire. That lead to implant is in varus, and 10 years down the lane, now it's showing some evidence of loosening, but at least 10 years she could survive with the same implant. Now, sometimes the fracture is type B, but move to type C with time. So this was the initial X-ray. There's no fracture in the post-op X-ray. You can't see anything. But within 2 weeks, the implant sunk in and the middle femoral calcar has been moved out. That means the fracture was there intra-op. We missed it and it moved down. So this basically now the implant has sunk in. You need a revision and you need to fix the implant with the newer processes with a diaphyseal fixing stem. That's the intra-op. You can see the posterior part of the which the anterior cortex was fractured. So in a posterior approach, you can't see the anterior cortex after putting the prosthesis. So the fracture was missed. Now type E and F usually happens in a revision scenario when we try to ream the distal part of the canal, we try to broach or we put a component in. If you find this after the post-op X-rays, then you tend to see whether your fixation is stable or the fracture is not displaced, then you can wait for some time. Or if you find it intra-op, you need to fix this with either of the methods. Now, here's one hemiarthroplasty where the prosthesis broke out. And usually in these kind of fracture of the prosthesis, there is a bone formation underneath the tip of the stem. And that leads to drift your stem away when you are trying to fix the prosthesis and the stem came out from the tip of that bone formation. So surgeon found this intra-op. He tried to fix this with an inadequate cerclage wire, which is actually the tip is still lying outside the canal, so it's not a good fixation. So we had to revise this with a newer process with a longer stem to bypass the fracture side and heal well. Type G is when it happens below the prosthesis or from tip to the going down up to the knee. It can happen while relocating the hip also after the surgery, revision surgery, when your assistance is too aggressive, and in these elderly patients, rotational force causes much significant fracture. So here's an example. That's a pre-op X-ray of the patient. It was in cemented processes, but unfortunately the cement was more down the stem rather than around the stem. So in these cases, what we do is we tend to use our interlocking reamers. So we use a guide wire. On the guide wire, we tend to ream so that we don't drift away towards the cortex. But even then, you need to see this under the C-arm. You see now there's a centralizer in the canal and there's a big chunk of the cement, which is still going to drift away your reamer towards one cortex, and that can cause the break. So under the C-arm, in different views, you need to hit that cement fragment and take that out, and then only you can ream in the direction. When we try to put the stem in at the tip of the stem, we got a fracture. Despite everything doing perfectly, there was a fracture. Now, this was the reason because the femur was a bit more bow than what we expected, and that led to fracture. So we decided that the fracture is going down in the C-arm, it is reaching up to the supracondylar area of the femur. The available longer prosthesis available on table, we found that it's still not going to reach to the level of the beyond the fracture line. But even if we put this, at least we can get away with some cerclage. But when we tried to put that in, we found that the bow of the femur is not allowing the process to go in the center of the canal. So we moved back to the original plan of the shorter prosthesis and fixed the fracture with the normal AO principles of the fixation. So all this armamentarium has to be there when you're doing these revision scenarios. So that's the post-op X-ray. And in 3 months, the fracture heals. So biomechanics helps you in proper healing. You need to address the problem right there at the time of it's happening. Now, one very interesting study is that out of these different constructs, which one is the best? So cables are stronger than wires. Dynamic plates are stronger than the original Ogden plates. Locking plates are better than the dynamic plates. screws and wires are stronger than only screws or only wire. And 2 plate or 1 plate with strut is better than the 1 plate. So you need to decide according to your scenario, which one is the best thing for your case in that on that particular day. So to summarize, the most important is to identify the fracture during the surgery and take the appropriate steps. Whatever method you want to use, you need to use that. If you find them in the post-op X-ray, don't hesitate to accept the problem and rectify the problem then and there, rather than patient landing somewhere else and needing a major revision for the problem. Prevention is always better. During the dislocation of the hip and relocation of the hip, during cement removal, during canal preparation, and during the component insertion. I thank you all for patient hearing and waiting for me till the end. Thank you.
So any question? So the important thing is while rasping, you have to be, maybe sometimes if it is too tight, then you hammer it, wait for some time, take it little out, then go in. So that will help us to prevent the fracture. But you cannot do it with the final stem. You cannot push and pull in the final step. But that will help us to prevent this fracture.
So
And
back and forth rasping is the best way. Sometimes even if you see that your templating is showing size 3 or 4, but you are finding resistance only at 2.
Yes.
Then what you should do is leave it for some time, go on the acetabulum. Give it some time, give some time to the bone to expand. And then if you come back, you will be able to reach to 3 or 4.
Conversion of CC screws, fracture like a femur to the THR, the sclerosed things, ENT burst can be in hand. That will be useful.
Yeah.
Right. Thank you, Dr. Subhas, for the excellent talk. And now we have got the big moment for Miral, and Dr. Manish will take over.
Thank you, Dr. Subhash, and thank you, moderators. So we have some exciting product launch that we have lined up. My request will be, please be seated because you will see some drones flying around you. And so I request you to be patient for next 10 minutes so that we don't make you wait in between your lunch. May I request my colleague Tejas to come and talk about what product we are launching here today. Over to you, Tejas.
So thank you so much and welcome one and all to our master's course. So as Dr. Dimple Parekh has already said that, this is one of the big milestones that all of us were looking forward to from Merit. So let's see what we have on board and let us give a bit of rest to our thoughts, which I'm sure must have been flowing through your mind till now. So the typical journey that Merrill followed during development of this couple of products that we are planning to launch today. Product conceptualization, then going to the geometric design that we want to have our implant. Then what is the appropriate sizing matrix, considering the kind of population that we are targeting, Asian as well as European population. The prototype that we developed at back end, and then later on we went ahead and did a bit of lab simulations. Instrumentation, another important aspect of it, we did a multiple iterations and then came up with the best possible solution that we can. Scientific trials, feedback, and then later on we tried to improve on both the fronts, product as well as instrumentation. Then today, all of us, we have gathered for the launch. So let's see what we have in kitty. So this was our typical reaction to the final product. When all of our backend team and the front end as well as marketing team, we had a look at our final implant. So just to break a bit of ice, it is as hot as our implant Bionic Gold total knee system. And just to add on, it is as beautiful as our Latitude hip implant system. So we welcome you all to the journey of adding more to life. So as Manish sir has already said, there is something hovering above your head. So just be careful. So let's see what do we have.
In the meantime, may I request all our three course directors, Dr. Dimple Parekh, Dr. Deepak Dave, and Dr. David Shokart. By the way, as I was just naming all three of you, I just realized all three are D, D, D. So may I request 3D to please come on the stage and help us unveil the product.
So it is our long-awaited unicompartmental knee. We are launching it with the similar brand name, Opulent. It is Titan. We'll just have a look at how a real implant looks like. So this is how it is going to look like. So I'll request our course directors just to stay with us for another launch. In the meantime, I'll take you all through what are our unique features of the Opulent Uni. So it's a J-curve design for good anatomical fit. As we all know, titanium niobium nitride coating is biocompatible and it offers or helps the implant with overall longevity. So the same feature is going to continue with Unini as well. It has got dual pegs for good primary as well as rotational stability. On tibial base plate side, there are posterior dovetail liner locking as well as anterior click fit locking mechanism. Overall geometry is asymmetrically anatomically shaped tibial insert for optimum bone coverage. And then we have got chamfered anterior corner to overall reduce the risk of patella impingement. Then, as I said, there is something more coming at your way. So let's have a look. Just to tell you, this time there are two drones. we'll just request you all to be a bit patient because this was another long-awaited product from Merill's end. And we are happy to share the news that we are finally have this product in our kitty now. So this is our revision stem launched under our flagship brand of Latitude. So it has got multi-hole cup as well as long stem, and we'll go through the detailed features at later stage. So those are them. So as I said, these were long awaited products, but yes, we do have them in our kitty now. Thank you so much, sir. So some of the unique features of a long stem, it's uncemented and conical implant design, lateralized design for optimum biomechanical reconstruction. The CCD angle of 135 to give an offset of 42 to 36 mm to come up with or to mimic overall natural anatomy. Smooth rounded shoulder to avoid tissue irritation. Polished bullet tip at the bottom to reduce stress between implant tip and femoral bone. Overall circular cross section for intraoperative flexibility. And on multi-hole cup side or the coated material is TPS. Anatomical hole design of 95 for ischium and pubis, additional fixation. We have provided or continued with the overall feature of Libertas hip cup of rim lock to provide axial stability and derotation tabs for liner lock for anti-rotation. So yes, these are two products, and as we all say, overall, the tagline that Merill follows, we expect to add more to the life. And with the help of all of you, surgeons and customer partners of ours, we are expecting to add more to life for patient and more to the lives of surgeons with these two products. So thank you so much, and let's continue the journey henceforth. Thank you.
Thank you, all the three course directors, and thank you for your patient listening and time. I think it's time. We all are hungry. 1 p.m. We get back again in the same room at 2 p.m. sharp with the next session. Thank you.
So those who want to have a look at our plant facility and get a bit of robot demonstration, they can register themselves at our help desk or registration desk at the entrance. Thank you.
Surgery itself, then you can almost guarantee, yeah, you're going to get full movement, no problem at all. But only has got 20 degree of movement, then definitely you are not going to get full range of motion. But the patient might be happy. For example, this patient is very happy. He has got only 90 degree of movement only, but she's very happy because she suffered a lot. And her expectation not to get a full range of movement at all. Okay, so what we need to understand is the pre-op, what is the range of movement? What is the deformity we are dealing with? Severe the deformity, more chances of ending up with less range of movement, which patient has to accept it. That's the first thing I want to tell. And most of the time, patient is not expecting the range of movement. What they're expecting is satisfaction of the surgery. And that we can deliver by doing operation. That's the first domain that you need to think about. Next domain is surgical steps. So out of 10 knees you do, 9 knees are more or less straightforward knee. The one knee is the one which is a complex knee. I'm going to tell about the 9 knees which we come across, which is the main delegates. What they are looking for is a common knee, how they do operate. Okay, and follow systematically. Some principles you have to follow always. Be precise in your step. Have a routine fixed format. Consistently follow it and don't deviate unless it's really essential. So if you do these things, TKR is most of the times a straightforward surgery only. You don't have to complicate yourself. So the 6 things that I need to work on is alignment and bone cuts, sizing of the component, soft tissue balancing, patellofemoral tracking, and whether the design influences or not, and then the wound closure. I'll just going to tell a few points about each. So pre-op, one thing I have done about the drugs is avoiding hematoma is very important. So I've practiced giving tranexamic acid for many years. And I also found literature supporting that also. If you use tranexamic acid, there is a chance that they get better range of movement post-operatively. That's something I use regularly for all the patients who are having surgery. And alignment and bone cuts, if you go into that, there are certain things like if you don't establish the femoral cut correctly or femur section correctly, tibial section correctly, then you're going to end up with the inappropriate knee or a stiff knee. There are many literatures about it. So we have to give special attention to these things. And still I follow this practice of drawing the interepicondylar line and the wide side line in order to assess your rotation. These are the basic things. Even if you become experienced, you can still follow it, and you may not, chances of you going into a gross errors are very, very low. So rotation of the component is very important. Don't ever internal rotate. Always it has to be external rotation. Normally we keep about 3 degrees and variation can occur according to the deformity. If you keep internal rotation, then you will end up in problem with the tracking as well as you can have trouble with the movement also. Distal femur cut is the most important thing. Remember, distal femur cut is important for addressing FFD. So which indirectly means that you are not going to get full extension if you don't do it correctly. So full extension is very important for routine walking rather than full flexion. So in order to achieve full extension, first thing is you have to address the soft tissues like posterior capsular clearance, because when you have a tight knee, FFD knee, your posterior capsule is tight, anterior structures are lax. You have to address the posterior capsule first, and then if needed, you have to also address the distal femur cut. Maybe you might have to take extra 2 mm of bone, and make sure, think about your blade. Saw blade has got about a millimeter thickness. You have to cut that 1 millimeter also. Otherwise, you might end up in that extra 1 mm of bone lying on the tibia, lying on the femur. So make sure your cut is done snugly, which will help you for alleviating the range of movement problem. Tibia cut 2 mm from the damaged side. That is a basic dictum you have to follow. About the slope, it's a big query. You can do, I have practiced 5 to 7 degrees in most of the cases. And even if you do increase slope, though the literature says you will increase flexion to extent, what you might gain as per the literature is not even 5 to 10 degrees of extra flexion. So I don't think special attention has to be given, but real importance is you have to keep posterior slope, which has to be from 5 to 10 degrees. Increasing more than that is not going to make any benefit for you. Sizing of the component, I don't think we have a correct size component for any of our patients, because we don't do, because the femur and tibia are pre-matched. We have sizes like A, B, C, D, E. We have to fit one of those to that. So we are not doing an exact size. So we can end up with places like where you have coming in between sizes. I use anti-referencing system. In anti-referencing system, you will not notch at all. I think there was earlier discussion about between 3 and 4.5 degree. In an anti-referencing system, there is no possibility of notching. You should not be notching. Only in a post-referencing system, you can notch. So anti-referencing system, what you can do is you can undersize the component, which has got a small problem of bringing out flexion instability. But in my own experience, I have not seen patients coming with flexion instability as a major problem if you make a size from size C to size B. But if you upsize it, then they can have trouble like oversizing and slight tightness, and they can go in, end up in range of movement issues. So better than oversizing, you can go for undersizing, which might help you for getting your no big issues at all and also increasing the range of movement. So in anti-referencing system, try to slowly undersize if you are running up with the problem of in between sizes. So between size C and B, you can go for B. As a design influence, I think over the last 15 years, we have come across with so many high flex designs where they have modification of posterior condylar designs and all. And I think many studies have already shown that there's not big difference whether you do a high flex knee or a conventional knee. The amount of range of movement improvement that you are getting just because of high flex design is maybe very marginal. It's not very significant. So it's totally, I would say, it's totally a personal choice whether you want to use a high flex design or standard design. Is a personal choice. But what you have to address is other factors like soft tissue factors, bone cuts, and other things you have to address to make sure the patient gets good range of movement. Gap and soft tissue balance is the final test when you are trialing is polo test. Okay. So polo means pull out, LO means lift off. Polo test is done for extension gap and flexion gap. For example, in the polo test, the extension gap, the tibial component should not come out easily. And in the flexion gap, the tibial component should not lift off. But whatever degree it is lifting off, that's what the final range of movement the patient is going to get. For example, if the tibial component is lifting off at about 90 degree itself, then the patient will not get beyond 90 degree. That's what the dictum is. And the similar thing about patellar tracking also, the patellar tracking should occur without any discomfort. And what the movement the patient is getting in the gravity in the intraoperatively is the final movement that the patient will get. That's the movement that can be assured to the patient that whatever they get in gravity is what they are going to get. For example, say if this patient is getting gravity movement of 130 degree, then I can almost tell to the patient post-operatively, we can at least get 130 degree movement confidently if you do the appropriate rehab. So wound closure has always been a debate that you could do it in flexion or extension or 30 degree flexion. But there are a number of studies, there are big meta-analysis has shown that no big difference in outcome, whether you close it in flexion or extension. But my own practice has been like closing at around 90 degree flexion, and I have not found any big issues, and the patients are mostly comfortable. Analgesia. The post-op analgesia is very important. I always see that on the first day of post-operative phase, the patient has to be having a smiling face, which means you have given adequate analgesia. If the analgesia is not right, the patient is going to have problems. First day problem, they made higher chance of having problems at the end also. So keep that in the mind. You should have a good analgesia. And the summary of surgical steps is first, focus on the alignment, femoral and tibial cuts, soft tissue balancing, component sizing, patellar tracking. If you did all these things correctly, then your patient ending up with a good range of movement is very, very high. That's what my final dictum is. And at the end, post-op rehabilitation is not unimportant, very, very important. Cover thromboprophylaxis, do quadricep exercise from day one itself, ROM to the limit of pain. If you want, if you are fancy of using CPM, you can use it, because CPM can potentially improve the range of movement, drain out in 24 hours, mobilize full weight bearing, discharge, make it in 5 to 7 days. So your rehab team should work along with you without any problems. Future removal in 12 days time, and continue rehab for 6 weeks until fully mobile and having good range of movement. So with this, I summarize. Achieving range of movement, we have to be practical. And the necessity of full range of movement may not be essential in many patients. And follow systematic approach and assess preoperative range of motion and counsel patient realistically in what they are going to get. And what patient needs is satisfaction. It may not be the full range of movement, that's what they want. And follow surgical steps correctly, as wrong techniques can have disaster in range of movement. So just follow correctly and systematically, that good post-op rehab is essential. Thank you very much.
Thank you, Dr. Subramaniam. I think once we have these 2 rounds, and then we can have questions later on. Dr. Jyotish will deliver the lecture on common errors in the surgical technique of the knee replacement.
Before they arrange, I would like to take this 1 minute and thank the moderator and the whole Merrill team for inviting me. And you have a screen? Yes. Okay. For inviting me as a faculty and deliver this topic. The topic given to me is regarding common errors in surgical technique for primary total knee arthroplasty. I think the August House, all the participants must have done total knee arthroplasty. So it is futile to talk that none is totally unaware about this system, or none is totally unaware about the procedure or the exposure you need. But I would like to deliver in such a way, the way I operate, and if you follow those steps judiciously and observe those points on table, then chances of getting mal-aligned or mal-positioned or improperly balanced knee is very less, and you will get better results clinically as well as radiologically for all your patients. And I would like to thank Dr. Subramaniam for delivering very nice talk, and that made my talk also little easy, because he has covered few points which I wanted to highlight in my talk. So if we start the talk, Sure. So any procedure needs better exposure. Everybody knows that. So length should not be a criteria if you start operating few initial cases in total knee arthroplasty. I would say initial 50 cases or 100 cases, then you may modify and use different approaches like subvasters, midvasters, or very mini incisions. The particular situations normally you come across is the situation where patient is already been operated once and there is a scar there. So everybody knows, and I just wanted to bring this to the notice of all the participants, is always prefer the lateral most incision if it's a longitudinal incision, or put a right angle incision to a transverse incision, which is nowadays very rarity to see because we don't operate in horizontal incision any of the procedures around knee. Raising a full thickness flap is a very simple method, but many a times with a fibrous tissue and operating the case which is already been operated gives you difficulty in raising it. So make sure your whole flap has all the fatty tissue and you can able to see the fascia clearly without any fat on the fascia. So that will give you best chance of healing of those flaps in a very nice manner without any requirement of any plastic procedures, and ultimately a happy patient. Before proceeding to any procedure, I think evaluation preoperatively for important radiological signs other than the routine radiological signs help you to err in a major way during your operation and to get poor result after the surgery. And those are few of them is, I would always ask my patient or my X-ray technician to get single leg standing X-rays, particularly when you have a metaphyseal varus or obvious looking varus in patients, because that will give you the amount of lateral laxity the patient can have beforehand, and that will decide your degree of soft tissue releases, what you want to do on table, and that will prevent excessive opening of the gap either in extension or flexion. Other few are relative to patella, that is subluxation of the patella in skyline view, very thinned out patella for those who are replacing the patella. From the center where I operate, Ahmedabad, we have hardly few surgeons, those who regularly replace patella. Most of them, they do patelloplasty and debulking of the patella. Osteoporosis, obviously in inflammatory arthropathy, you have to be very cautious in putting your spikes and avoiding impression of your spikes, particularly when you are subluxating the tibia forward on the femur, because that will end up in a poor positioning of the implants and avoiding snug fitting of the implant on the bone, and ultimately early loosening of the implant can happen. Fracture malunions, when they are present or retained hardware is there, you need to have a facility to use like navigation or robotic arms, because your IM nail is not going to go in and you will not be able to start your procedure of distal femur cut first and then operating the rest of the cuts and balancing the knee. So these are the situations where you should take help of all the recent advances in TK in form of navigation or robotic or patient-specific jigs, anything you can use. To start, begin with, always, we are talking about a varus deformity, which is the most common deformity you come across in a primary knee arthroplasty patient. So I always start with a distal femur cut, and that helps in two ways. One, better exposure of a very tight knee and subluxation of the tibia, so that I can able to see the whole tibial plateau and decide my cut. Distal femur cut, everybody knows, but for the sake of completion, and I always follow this step when I expose the femur, is lining the white side line, drawing it, and put a small point medial to the white side line. That's what my entry point is. Then how much amount of anterior or posterior you need to start your drilling depends on the bowing of the femur, that you can evaluate preoperatively by lateral X-ray of the femur. Always over drill, so it will decompress the canal and prevent the chances of embolization to this patient. Suck it. How much amount of valgus? There is always a great deal of debate. How much amount of valgus is should be kept. Normally, in female patient, I keep a 1 or 2 degree valgus more as compared to male. But best thing is to get your pre-operative scanogram. It's not that costly, and you may come across few of the patients, those who are outliers, means they have a significant amount of femoral valgus with a significant bowing and varus deformity. And by just ordering this simple scanogram, you'll be able to handle those patients in a better and effective manner. Then comes to the most important cut of the tibia. I would consider this cut as the heart of the whole surgery. If you are able to cut tibia perpendicular to the mechanical axis without major slope posteriorly, if you are using PS system, which I do in almost 98% of cases of mine. So that is my goal. Always subluxation of the tibia completely and visualization of the posterolateral corner. That helps you in avoiding two complications. One is inadvertent cut of the popliteus tendon. If you don't visualize, you may cut the tendon with your saw blade. And second thing is, very rarely you may damage the popliteal vessels, which are lying more posterolaterally than the center or the medial part of the tibia. So these are the two things we would definitely help if you subluxate the tibia completely out of the femur. And by taking the distal femur cut first, it's easier to subluxate the tibia out of it. Then always align the tibia in two planes. So what I would say is always check thrice, means you check at the level of the cut, check at the tibial tuberosity, and you check at the ankle. And your coronal alignment should have, that rod should fall to the second metatarsal. That's everybody knows, but by erring in a bigger way, your cut may go into excessive valgus or may in excessive varus. So that should be checked. Easier way to do is 3-finger, 2-finger breath, but in few of the bulky patients, this technique may not give you the reliable confirmation of your coronal alignment. So always better to check at 3 points, that is tibial plateau, then tibial tuberosity, and then obviously at second meta. I would always mark my tibialis anterior tendon as well as the base of the second metatarsal while applying a stockinette and then applying a clingotrip. That will help me in checking those alignments on table as well as after the final implantation while finishing the cut. Minimum resection, as Dr. Subramaniam has told, I always follow defect side with 2 mm or 7 to 9 mm from the non-defect or normal side. This is the way I do, and I always check on from the lateral angle about the slope. It should not be too much when you are using posteriorly cruciate sacrificing implants, because too much of posterior slope in PS knee would definitely end up with post and cam problems. So it should be either perpendicular or inbuilt 2 to 3 degree of posterior slope. This is easier way which I found and avoiding too much of soft tissue release by not using a cautery. Once I finish my femur cut and subluxate the tibia, I always use the nibbler if they are overhang osteophytes anteriorly, and then keeping the curved osteotomy flush to the upper part of the tibia, I just walk the osteotomy around right up to the posteromedial corner. So it will take care of all the soft tissues which are tight and remove the overhang osteophytes also from the tibia. And then remaining soft tissue release can be done in a gradual manner. So you don't release all the soft tissues in one go. Otherwise, you may end up with excessively loose extension gap, which is very difficult to balance from the flexion gap. Always check for your laxity when the patient is under anesthesia and prepped completely. So the most important step is always aligning and balancing your extension gap with not more than 2 mm of laxity laterally or medially. Once you achieve this, then and then you go forward. Otherwise, you may end up with losing in between and not creating the rectangular space extension to flexion. So I always make sure that I have very nicely looking rectangular extension gap without more gap either medially or laterally. If required, then I'll go ahead and release the medial soft tissue, posteromedial structures at this juncture. This is what you see when you do your anterior femur cut. There are few points to be remembered in this also. This gives you more or less clinical acumen regarding how much amount of external rotation you have kept for your femoral component, but too much also is not advisable. Here, if you see, my lateral lip is going right up to the metaphyseal junction. That leads to too much of external rotation and may open up the medial space, leading to mid-flexion instability. So you have to be careful that you are not externally rotating in excessive manner. So this is what I would like to see more as compared to the previous slide when I finish my cut. I always start from the medial side. So the soft bone, and then you finish your cut laterally. And as discussed in pre-lunch session, I think Dimple Bhai noted about notching the lateral part. I would consider it is not a major issue and it's not an end of the world, because ultimately sometimes the patient gets better patellofemoral tracking with minor notching on the lateral cortex, and it prevents overstuffing of the patella from there. And the most important thing I would like to tell to young budding surgeons who wanted to do more and more cases in future to come is always stick to a single system or single implant for 50 to 100 cases. Don't jump in between. If you jump, you will not be able to understand the limitation of that system, as well as you will not be able to understand the benefits of the system which you are going to use for next patient. For example, I'll show you the few modifications which I do when I use this freedom knee system in next slide. Basically, there are two referencing system everybody follows. One is anterior, second is posterior referencing. Anterior referencing surgeons, they always take care that they don't open up too much flexion space, because downsizing the anterior referencing system will always lead to opening of the flexion space, because you are releasing the posterior cruciate also, that will open up 1 or 2 mm. And if you downsize, again, you are opening 2 mm more. So those patients will have significant mid flexion instability. So in those scenarios, how to check the flexion gap is balanced to your extension gap by using this freedom system. This is what I follow is, I decide the external rotation by putting those 2 pins. Then I ask assistant to put another pin on the distal hole, which is been given just above the posterior cuts of the jig, 4-in-1 jig. So basically there are 3 pins holding the whole jig. Now you finish your anterior cut as well as you finish your posterior cut, and then put your blocker there. Take out the whole 4-in-1 jig out and keep the whole, keep all the 3 pins there. Once you are satisfied with that, if you are not satisfied and flexion gap is too tight, you have 2 options. One is make sure your PCL is completely released. If it is not released, you release it at that time. Or because this is an anterior reference system, by downsizing, you are not going to notch the anterior femur. So you can still downsize 1 and add 2 mm of cut posteriorly. And then you again apply your zig back like the same which is being shown on the other side of the slide, and then finish your chamfer cuts, and then finish your notch cut and all, and then do the trial of the femur. So this is what the slight modification I have done when I am using this system. And this helps in ultimately, once you finish all cuts, and if you realize that your flexion gap is too tight, then it's too late to go back. So this step can help you in correcting your flexion gap tightness. Once everything is done, the most important thing I think we forget sometimes is to clean the bone completely, and the look of the bone should be like this, so that integration of the cement, which is required about 3 to 4 mm for the bone, will be nicely universally around the femur cut surface as well as on the tibia. So pulse lavage, I think it should be mandatory and it should be used judiciously in all the cases of total knee. If you are not using tourniquet, use tourniquet during this 10 to 15 minutes step when you are doing cementing of the components, because that will help you, or that is the only way you can get this bloodless field of cut surfaces. Always do hand pressurization. That's what I follow. I'm sure most of the people sitting here must be doing that. I decide depending on the amount of subluxation, means force required to sublux the tibia, which one is to be done first, whether tibia or femur. There is no fixed protocol for that. Always cement on both sides. So that is what I follow. I avoid only putting cement on the posterior condyle of the femur, because then it is difficult to retrieve if you are doing the femur second, once your tibial implant is in, and then if you are putting the femur and there is too much of cement on the posterior condyle, many a times in a obese, bulky female patient, it's very difficult to take out those cement. So better you don't put too much of cement on the posterior condyle of the femur. So there won't be extrusion. So whenever you do hand pressurization, I would suggest that wait for 2-3 minutes, let the cement becomes doughy rather than in a liquid phase if you are doing it with your hand, and then apply it on the bone surface and then pressurize. Using it in a liquid phase will lead to a lot of spillage of the cement in surrounding, and then it is very difficult to retrieve them. So this is all. Once I finish procedure, before cementing, I do periarticular injection. Many of them they do in Ahmedabad. I have one fixed mixture. Clonion, maybe depending on the medical status of the patient, rest all goes in a standard way, and all patients gets adductor canal block postoperatively. So this is basically immediate postoperative pain analgesia. If you give good pain relief to the patient, then the outcome of the patient and chances of those stiffness and fibrosis also reduce. There are enough paper to suggest that. So I would definitely stress on this. Closure in a standard way with a multiple layer closure, and normally I put a dressing in a flexion position. There are two smaller things, but I have found few blisters when patient goes for active range of motion. If the dressing is done in an adhesive tapping in extension, then those patients will have annoying blisters around the wound, and they also don't like that. So this is a simple tip step which we follow when we are applying a dressing. If it's adhesive dressing on primary base, then we put the dressing on the flexion position. I think that ends up my talk, and thanks for the patience hearing.
Well, these were the two talks which were by Dr. K.N. Subramaniam and Dr. Jyotish Patel. If there are any questions about these two, I mean, from the audience, they can always ask, and then we'll go to the keynote talk by Professor Sochot. If there are, you can please come. If there's any questions, I mean, you can go ahead. Otherwise, we'll move on to the next keynote address. I think there are not many questions. So let's move on to the next keynote talk. Professor David Sochot. He's going to talk about the 10 factors which are influencing arthroplasty. Must be an interesting talk.
So you can just continue with this one.
Okay, thank you, session directors, colleagues, and thanks to Meryl and to Amit Doshi for inviting me here. So this is essentially going to be a bit of a science-free zone, where I'm going to talk about just practice as it's involved in the UK today, and particularly England, Wales, and Northern Ireland, Scotland being a separate country almost. not changing. There we go. The top 10 countdown. Okay. Sorry. And in no particular order. So dual mobility bearings. As you know, the head articulates within the retentive poly and the poly moves within the shell. It's not bipolar or constrained. And you've got options, uncemented or cemented, ceramic or metal on poly. The aim is to get a greater range of movement to improve stability and reduce the risk of dislocation. So they're used in complex primary cases, and particularly revisions for dislocation and for femoral neck fractures. But there's always a trade-off, and the trade-off with these is greater stability versus wear and longevity of the implant. So what are the long-term results? And what about cost versus benefit? When you actually look at the National Joint Registry and the National Hip Fracture Database in England and Wales, there's a similar revision rate to unipolars when you use them for the management of fractured femoral necks. There's also a higher revision rate when they're used for primary THR, especially when it's the cemented metal on poly bearing. If you look at the graph at the bottom right, the red line is the dual mobility, and it's actually performing as badly as metal on metal articulations did. So there are concerns at this early stage. Number 9 is the National Joint Registry itself. It's now the largest in the world with more than 3.5 million procedures logged. It's got various subgroups such as research and PROM studies and the outliers that I'll come back to. Looking at what's happened over the course of the registry, the first report was in 2004 and the 17th report was in 2021. And when the NGR first started, the majority of hips being implanted were cemented, 54%. With the passage of time, that has halved. Uncemented rose and peaked in about 2012 and has now dropped off to 35%. And the big winner, the one that's grown with the passage of time, is the hybrid hip replacement, going from 13% and now being the most common form of hip replacement in the UK. And this is good because these are the actual 17-year results. You can see that the hybrid total hip replacement is outperforming everything else in the world of hips. It's outperforming cemented, and cemented is also outperforming uncemented. Although if you look at the knee replacements, you can see that total knee replacements are actually doing better long-term than even hybrid total hip replacements. And those are cemented total knee replacements. Also, I bring to your attention, you can actually download these reports from the internet, the data and the reports in the National Joint Registry, and it contains every implant combination, every age range of patient, and all the details on 3.5 million cases. This is the largest database in the world. So this is actually probably a bit of evidence-based practice. The first report was in 2004, became mandatory in England, Wales, Northern Ireland in 2011. Your hospital gets fined if you don't put enough information in. Some data is now available to the public to access. There's a report produced for each and every consultant at the end of the year, which is about a 30 to 40-page report looking at all aspects of everything that you've done that previous year. And we have to take it to our annual appraisals and job planning meetings. So you put my name in, this is the kind of stuff that you find. You'll see the hospitals where I work, my 12-month practice profile, 36-month practice profile, what I do with hips and the patients that I treated, and then the same for knees. You can actually see here my last 18 years of patient demographics, nicely summarized every year and updated by the National Joint Registry. This is the consultant level report. We can actually look at the unit that you work in. So I work in the elective orthopedic center, which is the black dot at the far side. And the fact that it's that far to the side of the plot means that we're the largest center in the UK. And we're below the red line at the bottom, which means we're a sublier or a positive outlier, which means our results are better than expected. So despite having about 50 surgeons working there using a variety of techniques and implants and robotics and minimally invasive surgery, we're getting good results. We're outperforming the rest of the country, which is nice to know. You can also, when we twice a year we go away and we look at our results with all the colleagues there, and if you can crack the code, you can work out which consultant is which. The two consultants, the yellow circles up on the red line, are at risk of becoming outliers, and I'll cover that in a minute, and the rest are performing well. So what is the outlier process? This might come as a bit of a shock to you. You don't want to be an outlier, because if you are, 2019, we looked at it, 77 surgeons were identified. A letter goes to your chief executive of your hospital and to you, saying, can you validate your data? You seem to have a problem. You then have to validate your data, come up with a plan on how you're going to correct your practice. This then has to be sent to the NGR and the Care Quality Commission. And if they're not happy with the response, you are no longer allowed to operate. This is serious stuff. This is the government, this is the NGR watching everything that you do. And this modifies how you approach your practice. It means you won't take on a new technique or change implants without having a good reason for doing so, because it can affect your results quite significantly. Robots, we've touched on earlier today. Yes, there is evidence that in unicompartmental knee replacement, robots are definitely helpful, and it's an operation that's crying out for help. Anything that you can do to make it better is well worth doing. If you actually look at total knee replacement and hip replacement surgery, there is, as yet, no evidence that robots are helping. You have to bear in mind the learning curve of using the robot, the cost of the machine and operator, and the space that it takes up in theatre. And also bear in mind that in the UK, 90% of robots are in the private sector. So why are people using it? Is it marketing? Is it driving private practice? Or do they actually believe that they're doing the right thing for the patient? As yet, apart from in unicompartmental knees, no convincing evidence. Brings us to the Orthopedic Data Evaluation Panel, or ODEP. This actually has a major bearing on the way that we practice in the UK. It was formed in 2002 to implement the government, the National Institute for Clinical Excellence guidance on hip replacement surgery. It then branched out into hip resurfacing, TKR, and shoulders, and is now giving 17-year ratings. We meet twice a year, we review submissions from the companies, we look at all the data collected, we look at what's happening in the NGR, and every 2 years we update the ratings available to the companies. Many hospitals in the UK will only use an implant with a rating 10A star or more, which means it's got good evidence at 10 years and more than 450 cases across at least 3 centres. And this is monitored, the whole process is monitored by the NGR, and it starts in year 3. The direct anterior approach, we had a lovely talk on this morning, said to be less invasive and muscle sparing, less pain, faster rehab, good for day case surgery, which is all the rage just now. Smaller incisions, so you can have better cosmesis, not always essential. Lower complication rates, yet to be proven. It has growing popularity in America. That is not always a good thing. It is technically demanding. A lot of our trainees go abroad to learn how to do the direct anterior approach. But you need additional equipment. You might need image intensifier in an already crowded theatre. And there's the issue of cost. This is my colleague, Richard Field, who's one of the major anterior approachers in Europe. And he says that all you really achieve is to steal a little bit less of the patient's life. Yes, the patient seems to do a wee bit better for the first 6 weeks or so, but after that, there's absolutely no evidence it makes any difference whatsoever to outcome. So is it worth taking the risk? Is it worth doing the learning curve? Is it worth compromising your exposure just to steal that little bit less? Why not do a mini posterior with a bit of piriformis sparing instead? It depends what works best in your hands and what your experience is. Number 5, beyond compliance. This is what happens in the first 3 years before you can go into ODEP. You enter ODEP at 3 years. This was formed in 2011, this committee, to fill the gap between CE marking, which means you're allowed to start using an implant, and getting your ODEP 3A rating. It's an optional service available to manufacturers, but not surprisingly, most manufacturers do come to us and ask to become enrolled in this system. It's independent, it's got nothing to do with the NGR itself, although we're monitored by it, we've got nothing to do with purchasing. So we perform a risk assessment, we help with advice on how to get into the market. We look at what data needs to be collected and which surgeons or institutions are ideal for trialing these new implants. We look at a lot of data, a huge amount, absolutely everything. And if any revisions are performed at all, we look at the notes, we look at the x-rays, we look at everything that's been done. We have review meetings, which are confidential, they're minuted. And if there's any adverse incidents, if I'm a rapporteur for one of the implants, I will be informed. And if the implant looks like it's an outlier, the health authority will be informed. But if all goes well, you get your ODEP 3A rating, and then you continue on your ODEP path. Number 4, we've been talking about here, alignment issues. What is perfect alignment, and does it really matter? And are we moving to an era of bespoke surgery based on the individual patient? So in knees, there are differences between men and women. We're all doctors, we all know that. There are differences, aren't there? Certainly in the UK, men tend to be bow-legged and women tend to be knock-kneed, hence the varus and valgus alignment that you put in. Ethnicity makes a great difference, as well as the demands of the patient, as was just discussed. We're going through a phase of kinematic or functional alignment just now, or interest in these things anyway, again, with no evidence that they do improve results. And what you get on the table does not reflect what actually happens when you're weight bearing. You know, if you've got the patella dislocated, you've got a tourniquet on, how does that balancing actually reflect what happens in real life when that patient starts to walk and weight bear? With regards to hips, we're looking at spinal pelvic mobility and functional orientation of the acetabular component. This is because we see lots of scoliotic patients and it makes positioning difficult, and also patients with stiff spines for various reasons. And this increases the risk of dislocation, or it does once you start to think about it. So you take standing and sitting x-rays, you assess the mobility, and you alter the cup position accordingly. There are various systems that will help you do this. There's the OPS system where you take CT scans to predict where impingement is going to occur. They manufacture jigs that you use during the operation to optimize the positioning of your acetabular component. And of course, some people are saying, use a robot. Why don't you just use a robot? They're cheap. Girth, getting it right first time. In 2015, Professor Briggs and Professor Howie went and visited every orthopedic unit in the UK that performed joint replacement surgery to establish what the practice throughout the country was. And they found a 6-fold variation in infection and complication rates, and also massive differences in the price of implants. So the aim of girth was to reduce variation, to set up complex procedure networks, to look at the number of operations surgeons were performing. The more you do, the better you get. Were the outlier surgeons actually just low volume surgeons? You wanted the best environment to minimize infection and high quality rehabilitation, particularly for knee replacement patients. You wanted to reduce complications, particularly infection, and reduce costs relating to procurement, loan kit, and especially litigation. But did it work? And it extended to every field of surgery now, and it's coming to anesthetics soon. So girth has spread initially from the orthopedic domain throughout all the specialties now. And when they looked at their first 5 years in 2020, they'd saved about £700 million. That's not bad. They found that 93% of hip replacements were being performed by 60% of surgeons, and these were very experienced surgeons. But they also found that there were 30% of surgeons just doing less than 10 joints per year. And the girth evidence was also driving the move away from uncemented total hip replacement to doing more hybrids and cemented total hips, particularly in older patients. So they've actually been nicknamed the cement police as well. And of course, day case arthroplasty. Hospitals are dangerous places. The less time you spend there, the better, particularly if you work there. And you want to reduce the length of stay, free up beds, improve productivity, and significant savings are possible. Again, we're following the American model. Is this wise? They seem to replace something that didn't work very well with something that's about to fail. So day case arthroplasty, you have to standardize your protocols, particularly your anesthetic protocols. That's where we've struggled, is getting the patients up and moving the same day because the blocks and epidurals have not yet worn off. You need a buy-in from all the members of staff, all the porters, all the domestics, all the nurses, all the surgeons. You have to have a safety net in the community, and we've got a 24-hour helpline as well. Your results, of course, are monitored locally. You have to set up a team to do it, and by the National Joint Registry, who watch everything that we do. So what is number one affecting arthroplasty in the UK today? No surprise, it's our new friend, the coronavirus. It kind of feels like old news, but it was only like 2 years ago that the first lockdowns occurred in the UK and in India. Looking at the latest figures worldwide, India with about roughly 30,000 cases per million, the UK 10 times worse, and the mortality rate 7 times worse, UK versus India. So we've been hit pretty hard. There's the rates per country. And girth, remember, originally an orthopedic initiative giving advice on how best to manage COVID, how to treat these patients. Girth has spread everywhere, starting from the orthopedic community.
Am I audible?
This is where I work, and in 2019,
let me know when to start.
Which was the largest arthroplasty center
he'll
in
tell
the
us.
UK. A standalone unit sealed off from the rest of the hospital.
Matthew, gown is okay?
In Epsom, which is the home of the Derby, if you're into horse racing, just south of London. During COVID, we were lucky enough to build and open a 6th operating theatre. So we're now operating at 125% of the 2019 capacity, and we're the largest arthroplasty centre in Europe. And my own personal waiting time for surgery is about 3 months. What's happening in the rest of the country? What was the effect of COVID and lockdown? Well, we found that in the 2020 registry, there had been about a 50% drop in the number of joint replacements being performed. The waiting lists have risen dramatically. About 1 in 5 people in Scotland is currently on a waiting list for something. This is the equation to work out how many years it's going to take to recover from this backlog. We estimate we're about 300,000 joint replacements behind where we should be. And of course, this is getting worse because not everyone's back to full working. We're probably about 50 to 60% capacity throughout the UK just now. So the plan in 2021 was based on 2020's figures. And they said if we can immediately increase capacity by 5%, we could clear the backlog in 10 years. The problem is there's been another lockdown since then. We don't actually know how bad things are and how long we were going to take to recover from this. And our Chancellor, Rishi Sunak, is not at all happy because we can't afford it. So that's the UK's top 10 at present. A lot of things influencing our choice and ability to choose. This has not been fake news. All of it is true. And don't forget, there is the Jeopardy quiz tonight, which we're hoping to see you all at. And hopefully the first prize will be a bottle of Amroot whiskey. Because despite the fact that I'm a proud Scotsman, it is my favorite whiskey, Amroot Fusion. So thank you, everyone. Any questions?
Well, Professor Sochard's lecture was of a very different dimension and perspective. So, I mean, it's eye-opening in many terms. We all should start thinking in those lines that how we can really help patients in a better way. Well, any questions? He's here to answer.
Are we okay? Am I connected to the auditorium?
The dual mobilities.
Hello, can I connect with someone in the auditorium?
It's relatively early day for dual mobility in England and Wales.
Am I going to get a feedback? What's going on over there?
French, who
is there sound?
Perform absolutely no follow-up on their patients whatsoever and have no national joint registry, but they seem happy with it. People aren't being stopped from using dual mobility, but the indications are being narrowed. People are being told to think again and to move away from the cemented dual mobility and away from the metal articulation to the ceramic articulation. Because the best performing articulation throughout the National Joint Registry is ceramic and poly.
Okay, Deepak, I'm going to start. Let me know who am I communicating with?
Done by the British talk.
There. Is Dr. Deepak there?
Live case.
Okay, thank you.
Dr. Amite.
Hi, good afternoon.
Yeah, may I request the moderators?
And the second talk will be after the second.
Dr. Deepak Dave and Dr. Alec. Am I able to see Dr. Alec from Russia? Oh yeah, please.
So please let me know when can I start.
Dr. Agrawal, this is Deepak Dave. Can you hear us?
Yeah, I can very well hear you. Good afternoon.
Yeah, all set to start.
Yeah, we are set to start. So just to give you a brief about the patient.
We would like this to have an interactive.
That will be.
So
let's see how it goes.
Some questions from the audience, and please.
I don't mind at all. Please don't mind if I don't answer in time. Okay, I'll get back in case I miss some point. Okay.
All right, you can start.
So this is a 65-year-old lady, Mrs. Sohan Biri, a typical varus osteoarthritis. Nothing special here. A bit of varus laxity. That's it. Okay. So I'll show the X-rays later. Let me. So we are going to use the standard parapatellar approach.
Tourniquet or no tourniquet?
We do use tourniquet, but this patient has a little bit of hypertension, so you might see a bit of venous oozing, but I have inflated the tourniquet. We'll just get it under control. So the plan here is to OPS type of a knee. Okay, nice. Artery. Artery. Nice. So she is a bit of overweight. You'll find a bit of soft tissues. Okay. Matthew, light, please. Artery. Artery. Knife. Retract it. So the standard parapatellar arthrotomy. Come here. बीपी कितना है डॉक्टर? Cautery.
Has this patient been given tranexamic acid?
Tranexamic, yes, it has been given.
Any idea about the BMI? You said it's obese.
She is 5'5" and she weighs about 90 kgs. Forceps. So I'm going to do a medial release. So I do a sequential medial release. The first part of the release is an exposure release. Then I do take off the osteophyte, both from the femur and the tibia. Needed, I'll go at the posterior middle release. So the philosophy that I work with is, and then do cuts on the femur side as per as dictated by the soft tissues. Nibbler. You. Dr. Deep. Knife. Retract. Cautery. So there is a big osteophyte on the femoral side, PFJ compartment. Okay. All right. I will turn back to the tibia, take the osteophyte, forceps. Wait. Suction, Satya. There. Curved osteotomy. Collect. And now I'll take down the ACL. Anterior horn of the lateral meniscus, because that helps me retract the patella. So now if you see, the middle joint is opening. I'm okay with that. So if a little bit of release is needed, I'll come back later. Cautery, please. Blunt. Wait. Wait. Big. Light, please. So at this point, if I feel the patella is tight, I'll take down the lateral patellofemoral ligament, and that helps retract.
Dr. Agarwal, any tip for the obese patients in patella?
Yeah, that's
revert or dislocate or subluxate or
yeah. So in obese patients, first of all, we try to make a flap on the over the lateral side of the subcutaneous tissues, because if you were to eat a space for that. Okay, that is point number one. Point number two is always be very careful of the tibial tubercle, because there are high chances of tibial tubercle avulsion in obese patient. And I don't evert patella in any of my cases unless you need it to take down the osteophytes. If they are big osteophyte, then I'll extend the knee and then I'll take down the osteophytes and then do my surgery. So I don't evert the patella while the knee is in flex position. Okay, flex. So I think my tibial release is almost done. A bit of posterior middle release will be required later. Nibbler. Semimembranosus and POL, that would be released later. A curved osteotomy, or maybe I would do it right away. Okay. Tibial cutting guide. Retract it. So you can use navigation. Those of nowadays we are using a lot of navigation in cases, but if you were to do it the conventional way, you align your tibial jig with the shin of the tibia, and then I'll see how much am I cutting later. Let me just secure my jig. Okay, measuring stylus. So if you see, I'm okay with this depth of cut. I'm cutting 9 mm from the lateral side. So MCL needs to be protected. You can use either a handbag or a woman, and ask your assistant who is holding the popliteals with him to push the tibia forward. Lost it. Nibbler. Keep it there. So I always insist that the posterolateral part of tibia must not be resected with the saw. That is doing excessive movement of saw. So this portion of the tibia, if you take out with an osteotomy, it is just a mental safeguard. Okay, cautery, please. Matthew, size 4 tibia. Alignment round. So I think I'm okay with this tibial cut. If there are minor adjustments that are needed, retract better. Okay. Pins out. Got it.
Would you always prefer to take the pins out, or you will try to keep it if you really need a recut or something?
No, I do it because I know that I've measured amount of tibia that we resected, how much was tibia. So we measure the tibial cut. So if it is to the desired thickness, then there is no problem. I'll take out the pins. Starter, how much? Starter. So always.
Agrawal,
Yes.
for this entry hole in a valgus knee,
Yes.
what would be your tip?
See, in a valgus knee, what I do is little off the topic here. I don't change my entry point. I change valgus correction angle.
Okay.
Yes. So we do the planning on, and we see with the intended entry point, what kind of a valgus correction angle do I need to make mechanical axis neutral. So usually it is about 3 degrees or 4 degrees. So it's not never 5 degrees in a valgus knee. So we are doing the right side, 5-degree valgus. Okay. Comma. Nibbler. Quadruple. So I'll see, just to make a brief mental picture what kind of, so this is a reasonable gap that I'm going to get after the distal femoral cut. Come here. See guide. Okay. Protect the skin. Okay. Nib. Keep the pins in place. Extend. Kapra. Mallet. Kapra beta. So with the 9 spacer, I'm okay. Full correction of, there was no flexion deformity, but this is neutral. And okay, pin plus. Mop. So we use this a sturdy Lahanbeck in the supracondylar area to lift the femur. Okay, sizer. D.
So you measured tibia 4, is that correct?
Yes, tibia was 4 and femur it's between D and E. So I size to D. Okay. I'll at this point retract please. I'll ask my assistant to lift the leg and see if my pins are parallel to the tibial cut, because I have established my tibial cut was okay. And now I'm going to see what kind of a rotation does this patient require for me to balance the flexion. I'll never do a release to make the flexion gap balanced. I'll alter the rotation. So it's a combination of tensed flexion gap technique plus measured resection technique. Relax, relax. So I'm okay with the rotation, and I think this size is also giving me a good fit. So I'm going to go ahead with size D pins. Another pin. C guide. I'll just check whether anterior part of the resection is fine or not. I'm safe here. Cutting flush with the anterior cortex. Okay. Take the pins off. Light, distal light. Karo beta. Soft. Baby woman. So this is not any instrument between the MCL and the bone. Check the MCL. Left, please. And be careful how far in you. So always a good idea to leave some bone behind. Okay. Right, please. ठीक नहीं बेटा, लाइट ठीक नहीं. Retract. Pin out. Screwdriver. Satya. Bone cutter. Retractor. Artery. Nibbler. Osteotome. Mallet. At this point, I'll take off remaining. So the lateral meniscus I lift better. Lateral meniscus, one needs to be doing the same on the middle side, because MCL is in close contact with the meniscus. So leave 2-3 millimeters of meniscus behind, at least in the body portion of the meniscus. Okay, nibbler, please. Box. There's no point in checking the flexion gap, taking PCL, because PCL adds 2 millimeters to your flexion gap. Osteotome. Relax. ऊपर की लाइट ठीक करो, ऊपर वाली. संदीप, लाइट ठीक कर बेटा. ठीक नहीं है, यहाँ ठीक कर. हाँ, निब्लर, artery. So there are certain, पकड़ो बेटा, पकड़ो. There are small vessels in the PCL that we try to of PCL sometimes bleeds. Okay, suction. Lift. Okay, nibbler. Artery. Nibbler. Trial method. Lift, let me see. Okay. Okay, try.
Putting that finger is going to give you some idea. You're going to get 9 mm, 8 mm.
Left, left. Alignment rod. Okay. So it's a full extension I'm able to get. It's a stable, coronally stable range. Lift it. Okay. Cautery. I'm happy with this sizing and this trial. Any questions? I'm going to do a procedure, but
Yeah, I think we have a next lecture from Dr. Dimple, which is on the advantage of
Patella?
patella knee. So we don't want to ask you those questions because he's going to cover
Right.
the finer aspects of this newer material
Yeah.
in his talk.
Yeah. So it's basically
One question we want to ask you is that you try to balance your flexion gap by correcting the rotation rather than doing the
Yes.
soft tissue, correct?
Yes, yes, that's correct.
I think that's exactly what Dr. Jyotish also and some other previous speakers told us.
See, the basic idea is it's a hybrid technique. So you do
Combination of both.
combination. Because many a times I have done a study with one of my postgraduates where we looked at with this technique what kind of a rotation do we get in post-op CTs, and most of the Indian patients will require more than 3 degrees of rotation in severe varus knees especially. So the results that we got was it ranged from 4 degrees to 8 or 9 degrees. So what I feel is up to 8 or 9 degrees you can give without any major drawbacks to PF joint dynamics. Okay, so it's a balance the knee inflection. Okay, lift please.
I think we can.
लगा के निकाल. सत्य निकाल. तैयार करो. Matthew 4 and D. Yes, D.
So are you going to replace patella or not?
No, I don't resurface patella. There are very few indications in my book to resurface patella. Patella resurfacing is like a religion, so you can justify on either side. लगा बेटा. करो करो. Because what I feel is, especially for our set of patients, their patellae are so small and thin. You reset patella and then do cautery on the periphery and then do cementing. So patella becomes kind of a non-viable piece of bone lying over there. And if you, God forbid, if the patient fractures that patella, it doesn't unite. Okay. Okay. Left, please. Lahan bhai. Leave.
So in this obese patient for the tibia, would you consider putting a short cemented rod at some stage?
Yeah, that's a very good point. But if I talk about my practice, I usually don't do that, but there's no harm in it.
Dimple?
It helps.
Do you have any thoughts on putting a short cemented rod in an obese patient?
It helps distribute the stresses. So in case this patient is not that obese, I would call her overweight, not obese. But in obese patients, yes, if you can put a tibia, it's a good idea. Stem tibia.
So what is your, Dimple bhai, your thoughts? Is it BMI or weight? What do you think? BMI?
बेटा जी थोड़ा फ्लेक्शन करोगे, आप थोड़ा बाहर निकालेंगे. Okay, mallet. So how to set tibial rotation? That's a standard. In a varus knee, you go with the anatomic points, which is middle and middle third of tibial tubercle. In line with that, you can align your tibia.
So advantage with the freedom, same tibial tray, as
Nibbler.
you can add the cemented stem. So you
Yes.
don't have to change. In some of the systems,
Yeah.
you have to change the tibial tray.
Yes, yes, that's a very utility point of this system. Okay. Sometimes this is a hack that I love to tell my fellows, that use an osteotome here, because this piece of bone is sometimes very sclerotic, and if you try to hammer a blunt rasp there, you may fracture your posterior middle part of tibia. Mallet. Pin puller, drill hole, implant खोलो बेटा. Implant Deepak. So, okay, wash kar. Your call. So we are ready with freedom as well as opulent here. So I think this patient has agreed for freedom knee. Opulent and freedom, they are both similar in design, and instrumentation is absolutely similar. So the discussion here is on technique rather than on the material, which I think you are going to have a lecture on.
Yeah.
Is that okay if I use freedom here?
Yeah, that's fine. The other question is, at what stage now you would be giving the local infiltration?
Just now, after doing a lavage, I'll be injecting the cocktail, the magic cocktail that our good anesthesia colleague, Dr. Darshan Singh Rekhi, has prepared. So, yes.
So Dr. Agrawal, I think we can probably leave you at this stage.
Okay.
On behalf of my colleague, Dr. Primachev, who is from Russia.
Yes.
He's moderating this session along with us and all the delegates and friends sitting here. We thank you for wonderful exposure.
Thank you so much.
And we need to move forward for another talk by Dr.
Yeah.
Dimple on the opulent knee. Right? Thank you, Agrawal.
Thank you. Bye-bye. Have a great day.
Thank you. Thank you.
I think, Manish, is it okay we go with Dr. Dimple's lecture?
I'm absolutely fine. Thank you very much. Off kar do. माइक मेरा ऑफ कर दो.
मैं एक में दे दिया, नीचे दे दिया भाई. इसमें Good afternoon. So you've seen a very nice surgical technique, how to do a posterior stabilized joint. And now I'm given a very technical topic, what is titanium niobium nitride and why we should use this implant. So many patients in our practice are coming with the metal allergy. So, you must have seen patient coming for 3 months, 4 months with the swelling in the joint. Sometimes you see some dry area on the lateral aspect of the wound. All these maybe because of the allergy to the nickel that patient do have. And that is what we are worried about. And the patient always feel that he or she has some infection in the body or in the artificial joint, and they eat your head out. And second thing is, we are getting more younger and younger patients in our practice, where we want to see that the joint should last longer, and how this titanium niobium nitride will help us to achieve that. That's what we are going to see. The use of artificial joint is ultimately going to wear out sooner or later. And the biological effect of wearing out is osteolysis, which is between the implant and the bone. And that is because of the bulk material and debris which is going to happen in the joint per se. For that, we have two different options. One is to have a better quality of polyethylene, and second is to have the better quality of hard material, which is available nowadays and which has been tested in vitro studies. So that is how we are going to reduce the polyethylene debris in to reduce the wear particles in the joint. What are the different materials available right now in the market? That is the different coatings. One is a titanium nitride, which is a diamond-like carbon. Of course, we do have a titanium niobium nitride. We do have a modification of the bulk metal that is called oxidized zirconium. And of course, we have a ultra high molecular weight polyethylene, which is where on the plastic side, we have changed the material well, we have increased the cross linking. All these things are really available in the market, or some of them are in a preclinical testing. So what is this titanium niobium nitride coating? So how they do it? It's a physical vapor deposition, where the material which has to be deposited on the metal, this material has been vaporized, and that is in a very closed the environment where these deposits, that is, those vapors are deposited on the chromium cobalt. This is a very highly technical thing, and it has to be done in a very vacuum chamber. So this ceramic coating technique, which is utilized, is a physical vapor deposition, which involves the coating the implant during the vapor phase of high vacuum chamber, that is in which the nitrogen is added every time. And in this manufacturing process, the coating is securely anchored in several atomic layers. So there are small atomic layer, and on this there are multiple titanium niobium nitride coating is being done. The important thing is the system, how they do it, and that reproducibility has been achieved with the control process of producing the coating consistently with a high quality. That is very, very important. Unless we achieve this, probably the result of higher hard material we are not going to achieve. So this coating, the best why we use this coating? Because this is the best tribological performance in the prevention of, in the presence of albumin. So that is the natural joint fluid which is being, and this material is the best performance in presence of albumin, and it gives a hard, smooth, low friction, and has the best wettability surface. So that is why it gives a very good lubrication between the metal and the polyethylene, and this properties reduces the wear, hence lowers the release of chromium cobalt ion, which ultimately leads to the osteolysis. We do have an in vivo study of up to 8 years, and rest of the studies are less years. So we have a maximum study of 8 years right now. So how do this help? The release of cobalt, chrome, and nickel ions from the coated and uncoated specimens were taken. So there are chromium cobalt, and another were chromium cobalt with the coating of this titanium niobium nitride, and both were checked, and there was definitely there was some reduction in the allergic potential in this coating. So that helps us for the less allergy, which is the most added advantage of these metal ions, that is for sure. The longevity is still, we don't have the long-term data in vivo. So the release of allergic ion, if it has been done, so if you see that the uncoated, I'm sorry, it's not coming, uncoated chromium cobalt has a high allergic ions which are available in the joint. Now, if you see the titanium niobium has abrasive wear because of the material which moves on the poly, which leads to abrasive wear, and for that we need more and more hard material. So if you see chromium cobalt on the right side which is 3 in GPA. And if you see the titanium niobium nitride, which is 24, which is 8 times harder than the chromium cobalt. And if you see in between, there is a zirconia and ceramic biologs, that is the pink ceramic which is available. So even from the zirconia, it is 3 times harder. If the wetting angle is by 20 degree, the resultant improvement wettability is much higher, and these implant surface are it's much better for the body fluid. So that is how also we reduces the wear in these patients. So it's a this better wettability increases the lubrication and decreases the coefficient of friction force. And how this property of titanium niobium nitride helps is the color is not an important thing, but then we have got the coating thickness of 3 to 6 millimeter, the less adhesive strength, coating hardness is far better and superior, wear is less. It's not a cytotoxic or not genotoxic. The sensitivity to the body part fluid is less, and the no product related tissue reaction happens in the this product. So it is one of the best product available today in the market, but still we need to have in vivo long-term study as far as the longevity is concerned. But definitely we know it is much better for allergic patient. So any patient which comes with the saying that I'm not able to wear the earrings or the bangles, then we straight away use these, and they do feel better. They don't have any issues of allergy. So this surface is, it's more useful for allergy and wear protection. And macroscopically, the titanium niobium surface presents a metallic light golden yellow in appearance, whereby the coating forms an extremely strong bond with the implant. So what is the advantage of this material? It's outstanding biocompatibility, the allergic prevention, the hardness superior to the chromium cobalt based alloys, higher wettability with synovial fluid, which reduces the coefficient of friction, superior surface hardness, low friction articulation, long-term chemical stability, avoids inflammation and endoprosthetic loosening, and extreme adhesive strength. So all these things helps us to have a better allergic implant, and maybe it is going to last longer. Okay. Thank you. Okay. Many questions. I thought Dr. Deepak sir is going to ask me. So if you are using for allergy purpose, then it won't make any sense. But if you are really thinking of using for the longevity of the joint, it does make sense. Because locking mechanism for both the system is same. So if you are just thinking that I want to use it for a long-term result, then yes, if you can do a hybrid kind of a thing. So one side, this titanium niobium, the another side is a metal. Okay. In vitro, yes, they have done it. In vivo, we don't have. Right. Thank you. Thank you very much.
Thank you, Dr. Parekh, and thank you everybody for the patient listening once again. So I would take another 10 minutes of yours to do a campaign that we are going to actually run. So we are calling this as treatment zaruri hai, which actually means that treatment is essential. And the whole idea behind this campaign is actually to increase the awareness, because we believe that if the awareness about replacement surgeries is better, if it improves to whatever level it is currently, we do foresee a huge gap to be bridged in terms of available patients who are affordable and would like to undergo a treatment. Majorly, it is knee replacement surgeries, and what we've found out is year on year, the disease is on the rise. And we had some Times of India survey which said that this is something which is one of the biggest killer disease after the cardiac